Good morning, everybody. My name is Councillor Argento. I'm the chair of the Health and Wellbeing Board. Welcome to everybody, and thank you for attending. This meeting is being webcast, so members of the public can watch us online. There are no fire drills planned for today, so if the fire alarm goes off, we need to evacuate the building, and I believe we go through the anteroom, but we'll follow Claire out of the building, and the assembly point is at Tudor Square. Toilet facilities, for those of you who don't know, the gents are just out of the room on the left, and on the right, and the ladies is along the corridor, going to the left and right, and along that corridor, just opposite the chief exec office. And we'll just go around for a quick round of introductions. So I will start on this side. Yeah, thank you.
Thank you, Chair. Jason Deach, Democratic Services. I'm David Black, Medical Director for Development at Sheffield Teaching Hospitals.
I'm Alexis Chappell, I'm Director of Adult Health and Social Care in Sheffield City Council.
I'm Emma Latimer, I'm the Executive Director of Place for Sheffield and South Yorkshire Integrated Care Board.
I'm Lee Sorsby, I'm GP at Sheffield Place, ICB, and also the Clinical Lead for Health Inequalities.
Hello, I'm Judy Robinson, I'm the Chair of Sheffield Healthwatch.
I'm Dan Spicer, I provide policy support to the board.
I'm Kay Kirk, I'm Health and Wellbeing Board Support Officer.
I am Helen Steers, the Director of Strategic Partnerships at Voluntary Action Sheffield.
Good morning, I'm Sharon Mays, I'm the Chair of Sheffield Health and Social Care Trust.
Catherine Roberts-Shaw from the Sheffield Health and Care Partnership.
Greg Pell, Director of Public Health.
Thank you, and we've got Claire here next to me, just helping us with the tech. I have quite a list of apologies for absence. I'll read them out, and then Claire, if there are any more, or Jason, let me know. We have apologies from Ruth Brown, Sandy Buchan, Councillor Douglas Johnson, Andrew Jones, Kate Josephs, Ben Kemp, Kate Martin, Joe Rennie, Councillor Mick Rooney, Tony Schwartz, and Rob Sykes. Are there any more than those? Not that we know of. Okay, so we can go on to declarations of interest. Is there anybody who needs to declare an interest on any of the items on the agenda? Brilliant. Let's move on to number 3. Public questions. I believe we have a public question from Sophie Rutter. Would you like to come to the microphone and put it on, and you can ask your question? Thank you.
Hi, I'm Sophie Rutter from the University of Sheffield. I've been working on a project that's been looking at mobile workers' access to hygiene facilities. And by mobile workers, we mean people who are working away some or all of their day from a fixed workplace. So it could be like police, it could be cleaners, construction workers, utility service providers, and things like that. And they're having real struggle to get to hygiene facilities, and they're often not able to get to a toilet in their working day, or they're not able to drink water. They're not drinking fluids to avoid needing to go. And my question is, particularly in the light of the decline in the provision of public toilets, and also the closure of several major department stores, what plans has Sheffield got to provide more public toilets?
Thank you. Thanks, Ruth, for that question. Is it okay if I call you Ruth? Is it okay if I address you as Ruth rather than Sophie? Sorry. So not okay at all. That's a good one. Not okay at all. Is it okay if I call you Sophie? Okay, thank you. I'm going to try to read the answer here. Thank you for asking the question. It's a really, really important kind of topic, and we are aware of that. The Council recognises that public toilet provision is important for supporting accessibility and health and well-being. However, the provision of public toilets in some sites may only be financially sustainable if they are provided alongside other facilities. So, for example, in our parks, this may mean public toilets being provided alongside a refreshment offer. Sheffield City Council has a range of existing, maintained, managed facilities within many of our key sites across Sheffield, including Encliffe, Millhouses, Firth, Forge Dam, Graves, Exel Woods, Stannington Park Cafe, Centre in the Park and Norfolk Park, the Botanical Gardens, Western Park within the museum, and a full list of those can be provided. We have been working with partners to establish facilities that include toilets and toilet refreshment facilities across green spaces. These include Shirebrook Valley Visitor Centre refurbishment, Hillsborough Park, Age UK, Sheffield Coach House Cafe facility alongside the Gathering Ground suite of buildings that includes the Makers Shed and Pavilion. We have a range of projects that are in development that aim to provide toilet refreshment facilities, including Whalebrook Park, new cafe and toilets under development, Parkwood Springs, new kiosk and toilets provision planned as part of phase 2 of the current Trail and Track project. Hillsborough Park Library is progressing a project to enhance access and toilet provision linked to the park. Hillsborough Park Pavilion, changing places facilities. There are also some future projects in the early stages of development that will include public toilets provision if feasible. These include Hillsborough Park Activity Hub and Exfield Park Cafe. We are also working with partners on plans and opportunity for facility at a range of further sites. Although there are limited toilet facilities in the city centre run by Sheffield City Council, the only ones currently for public use are the Containers 1 and in the Moor Market. There are a number of businesses that allow use of their toilets. For example, McDonald's allow blue light workers and delivery drivers for the use of their facilities. All Sheffield City Council staff are given access to nearby depot, housing, offices and libraries, etc. The responsibility for ensuring employees' health and well-being, including welfare facilities, sits with the employer, who should assess comfort breaks and welfare facility. The Workplace Health, Safety and Welfare Regulation 1992, Section 20, 21, 22 and 25 lay out the requirement that the employer needs to meet for sanitation, drinking water, washing facility and facilities to rest and eat meals. However, the application of this regulation for temporary work requires the employer to discharge its duty to Section 20 to 25, so far it is as far as reasonably practicable. What that looks like for specific work you will need to be tested. Again, the employer policies. It is open to employers to engage with the council to access the availability of publicly accessible facility as part of meeting the requirement of the regulation, but it remains responsibility of the employer to ensure appropriate provision is available. Because this is the official answer. I'm sorry, but my eyesight is too rubbish for seeing such as. However, I think we can still explore other things. For example, we could look at how we can encourage businesses to allow people to use their facilities. And I think Business Sheffield does do some work on that, so maybe we can liaise with that and see if we can have kind of scheme or something. I mean, that's my personal kind of take on that. I had quite a few emails during the pandemic where the facilities in the parks were closed, and it was particularly difficult for people with disabilities, not just people who worked. But I remember stories about lorry drivers on the motorway that couldn't stop anywhere during the pandemic because they weren't allowed in facilities. So it is a real issue with people who work on the go. So thank you for bringing it to us. And that is what's available. Yeah, we're happy to explore and to work with you as a partner to see if we can do more.
So thank you for recognising the issue, and thank you very much for a very detailed answer, and I'll have a closer look at that after this. Thank you.
Okay. Thanks, Sophie. So I have item number 5, Healthwatch update.
Thank you.
I usually draw from our monthly what we're hearing report, so what people have phoned up or got in touch with us about. But I thought since it's Christmas, I would do a couple of good news stories. So, and they're really about two longer pieces of work that Healthwatch has been doing, and I think they have some generalisable lessons to learn, if I might. So just the first one. We have a micro grants programme. It's called Speak Up, and we give small voluntary organisations £2,000-3,000, it really is little, to do some work about the health of their particular client group or their community. And one of those was with the Sheffield ME and fibromyalgia group, and they did a piece of work on barriers to accessing support, and did an online survey and a personal survey. Boy, they found some rich findings and some interesting findings, I think, which services would, I think, find useful, and we have been talking to services. But some simple things, which seems unbelievable. Somebody saying the ability to bring a support person along to an appointment. Just sounds obvious, but really important. A lot of people saying it was really hard to get a diagnosis, that I just wasn't believed. And we've heard that for a long time. But I think by bringing together this work and facilitating a conversation with services, it's a way to hear directly from people what their experience is and what often very small things would do to make a really big change. This is the infographic about it, and I've got a few people want it. There is a much longer report. The second one is a piece of research we did about older people's experiences of living in a care home. And again, there is a report. I have to say a lot of really good news. People have good experiences. It's certainly not all terrible. But a couple of things that really struck me. One was, and it's sort of obvious, but how terrible an experience it can be to the prospect of going into a home, the fear of that, and how handling that and the communication and that point of entry, how important that is. And the other one was about food. I mean, food is a really critical point in older people's lives in those homes. But of course also, and I just a little quote here about relationships, and they've been disturbed really, I suppose, by COVID, but somebody saying, I've made good friends with one of the cleaners. She sits and chats for 10 minutes before she starts her work. She makes me feel wanted. And there are lots like that, which are really sometimes quite heartbreaking. We've been working, we was talking, Alexis, with the local authority and with the care homes. An interesting difference between, I think, some of the smaller homes and the big chains. You can guess which is which about people's experience. And there is a group looking at how we can help to make those changes by encouragement. And I think that's really important. As I say, really simple things matter. We realised when we were doing this work that there were almost no people from black and ethnic minority communities in those homes. Just, we know that's what we found out. And we're now doing a particular piece of work with those communities about what are the barriers to access, why are people not there, and what's their experience. So that will be coming out soon. I just want to pick out just a few. I mean, they're obvious really, but for the record, getting people's lived experience really does enable services to look and think about what is it like to be me? What matters to me? It takes time. I mean, doing those interviews with older people, you cannot go in, you know, with your, here's my 5 questions and could you answer them now? You can't do it like that. And that's often the case. And we need to sit back and be willing to listen. That's quite hard. The importance of small particulars for health and well-being. And those things really matter to people. So I think there's ongoing work. This kicks off that sort of stuff. I think they're both really good examples of how we can listen to people and how services can use that information to make really important changes. So few real copies of those reports. It's all on the website if you want those. Thank you.
Thanks, Judy. Thank you very much for that. I was at the last meeting of the ME and chronic fatigue meeting. It was very interesting. Actually, I have a copy of both. I've got the long report from that, and it does make very interesting reading. Is there anybody else who wants to? I've got Alexis and then Greg.
Hi, it's Alexa Chappell here. Just want to say thank you to Judy and to Healthwatch particularly for the care homes report. I think it was a really fantastic report, and I think particularly the research around that's going around care homes is really fantastic. And certainly what we've done is we think that what we want to do is work in partnership with Healthwatch to use this to look at our transformation projects around care homes over the next year. And I know our teams have been in contact to go and look at that as we take that forward. And I personally thought it was a really helpful report, and I think what's really key from that is that we ensure people's voices are absolutely the core to how we continue to ensure excellent quality residential provision across the services, but more crucially, which is really the key point from the report, is actually the experience of individuals move into a care home, which is the key thing. And I think, so just want to say really thank you to the team. We found it really, really valuable and absolutely committed to the joint work in it, but as the next stage in the process of change.
Ditto, thanks to Healthwatch for doing the work, quite impactful. Specific question, and maybe put Emma on the spot, apologies in advance. The sort of really neat example of how to get lived experience and simple things. How well do you think our machinery is able to sort of respond and react to that appropriately? There's a bit of cultural stuff in there, and then there's a bit of, does the machine enable that to happen in, as Judy said, a kind of a robust and sustainable way? I welcome a sense of that.
Okay, thank you. I think we had this discussion earlier in the week, really. I don't think we've quite got public engagement rights in the city. So what we want to do in our new partnership arrangements is to co-design that in a very different way to ensure that we do get that richness from different sectors, from grassroots, from voluntary community organisations, and actually that we start to see, if we get feedback, where does that go and how do we then hold ourselves to account for delivery of that? So it's not that we're just receiving feedback and saying, thanks very much, we've noted it. We're actually demonstrating what we've done with it. So I think in our new partnership arrangements that I'll come to later, I really want to get into a different way of working with our public and our communities and our patients and population and residents in terms of how we design services in partnership. But I think there is still a massive power imbalance between statutory organisations and citizens in terms of who gets to make decisions on how we spend health money. So looking forward to working with people over the next 12 months to really change that balance.
I mean, I think Emma's right, I agree about that. And I think with these longer term projects, that conversation can be had. I think where there's a specific issue and people really get hot under the collar and start protesting, the system finds it much more difficult to respond to that in an open way. So, and I also think that some of the formal consultation processes, which seem to me to be quite rigid, are much less willing and able to really listen to people. The timescales are too short. Usually decisions have almost been made by the time you get to talk about it. So I think it depends on which sort of engagement you're talking about. I think if we could make more like that in those other two, that would be real progress.
Yeah, just a couple of points. I think absolutely with the general engagement bit, I think we could do it better. And I think the bit around the chronic fatigue and the fibromyalgia, as a GP, that's proper GP work. You know, that's complex. So it's a diagnosis of exclusion. You can't do a test and get the diagnosis, and then there isn't a clear pathway for treat the patient. But it takes a lot of time. So I think the thing I would say is that there's a real willingness to want to do this better. But unfortunately, we're in a system where people are just looking purely at numbers. So a good example would be, I was in practice the other day. I dealt with one call where I actually gave advice to 4 members of a family. It took me about 2 or 3 minutes. The sort of patient that you describe, I would probably spend 20 to 30 minutes dealing with that patient. that counts as one consultation. The 4 count as 4 consultations. We're having league tables where we're actually judged on the number of consultations. So my frustration at the moment is that there's restricted time to manage these patients properly, but we're also fighting against a system that actually just, I think, you know, never mind the quality, feel the width type of approach. You know, it's that to me is proper quality general practice. That is family medicine, that is holistic medicine. But we're in a system that really is pushing everything towards just rattling through people very quickly. And I think that's where I'm hearing a lot of frustration from the front line, that you don't have the ability. But also, if you do spend the time, you're getting criticised because you're not rattling through the numbers. So I think it is really quite complex.
Thank you. I think that's why it's important to have these conversations, because we've got to find a way to overcome that. So how do we do that? And that's why I think Emma's contribution to looking at how we work together is really important. Emma, do you want to
just come back on that, Chair? I think again what we're keen to do is to see people as people rather than conditions. So we tend to consult very much around conditions rather than actually what do people want, what do their families want, and often these aren't health related conversations. They're actually about how do we support people to live their life, and that cuts across the wider determinants of health, which is why our partnership working is really important around housing, education, skills. All those things really matter to people. I think, you know, we've got pockets of great work, but we really need to change how we think, and hopefully through our new partnership arrangements we can build on the good work that's already in place and really start to make an impact on people's lives.
Thank you. Music to my ears, talking about people and not patients. Is it okay if we move on? I've got item 5, health protection update. Greg, I think that's yours.
Yeah, so whilst Ruth gets set up, who'll do the talking, this is the thing for which my head will get chopped off, and Ruth's job is to keep me out of jail. Always a topical issue, quite topical at the moment for all sorts of reasons Ruth will pick up on, and we've established that the Health and Wellbeing Board is the frame of reference and the point of accountability for all things health protection. Ruth brought a report 6 months ago, and this is today's update.
Lovely, thank you, and thanks for that introduction, Greg. So yeah, this is the 6 monthly update, and people will have seen the paper that I've sent round, and I'm just going to pull out a few key items on that. This paper is about risks across the system, areas of concern in relation to health protection. So the first one that I wanted to bring up, which is really very topical at the moment, is under the managing respiratory diseases and winter generally, and obviously people will have seen in the news some very sad cases of some children who've died of invasive group A streptococcus, and I thought that the board might appreciate a brief update on that. Very aware we've got clinicians and colleagues who are GPs in the room who might want to add to that as well. I think it is winter. We have got a lot of cases of, it's normal to see a lot of cases of, for example, sore throats at this time of year, but with group A streptococcus, obviously that can manifest in a number of ways, including a strep throat or scarlet fever or a skin infection. And what we've seen this year is that group A streptococcus cases have come a bit earlier than we might expect normally, and we've got quite a high rate of, for example, scarlet fever cases. That's across the country, and that includes Yorkshire and the Humber. And that has been translating this year into a higher than expected number of cases of invasive group A streptococcus, which is a really serious infection. What we've been doing, and I know health colleagues have been doing this as well, is trying to give information and communicate with the public about when they should seek help, what's something of concern, what's something that they should wait and see about. And for example, in the local authority yesterday, 2 days ago and yesterday, we sent information out for schools to share with parents, and we've had feedback that has been well engaged with by schools and has been shared with parents, and we're hoping that that's going to be of help and assistance, because we're very aware that NHS colleagues are under a lot of pressure and capacity, and there's substantial waits at emergency department as well, which obviously doesn't help anybody, doesn't help emergency departments, doesn't help somebody who needs some urgent attention for their child. So I just wanted to say that, and to say that we have been doing quite a lot of communication on that. I'm sure that colleagues will have a bit more that they want to potentially say on that, but that's where we're at with that at the moment. And it is the case that some years we have higher years and some years we have lower years, and this is a higher year. But we know that also we've got the situation amongst parents and the public generally where they've got a high level of sensitivity to diseases and infectious diseases, and I think that also influences people's behaviour because they remember how it was in COVID, and there's quite a lot of anxiety. That's what I'm reflecting on, definitely, anyway. So happy to talk about that shortly, or I'll carry on with other aspects of my paper that I put. We have an ongoing concern about the uptake of childhood immunisations, obviously really important to prevent against vaccine preventable diseases. Our rates have been increasing since we came out of COVID, but we are still concerned that we have particular parts of the city and groups where uptake is not as high as we would want it to be to protect our populations. And you'll have seen in the appendix that I put a map, but I'm very sorry because I've printed mine out and it's in black and white, and I realise you can't see it very well in black and white, so I hope you're able to look at it in colour. But shows, again, as many of us know, that we have got inequalities in uptake of vaccination, and that is linked to socioeconomic deprivation. And I know that from the meeting that we had last time, where we talked about how the way that vaccination is funded in primary care potentially exacerbates inequalities, and I know that the chair last time wrote to NHS England about that, so I wanted to just feedback that that had happened. It's really a plea, and I'm going to make this plea every time I come, for all partners to work however they can to increase uptake of childhood IMS, and just a particular mention of the Children's Hospital, who are looking now at how they look at children and whether they're up to date with their IMS, and provide that in various places, and they're starting a pilot on that with outpatients. So when a child comes to outpatients, to look at whether they're up to date with their IMS. And that's a really important thing for us to continue to do. So that's one of the things I mentioned, increasing uptake of childhood immunisations. And then I just wanted to mention something else that we're doing across the system, which is the review of our mass vaccination and treatment plan. This is a really important thing for us to have in place. You don't use it every month, but when you need it, you really do need it. And we had an incident earlier in the year of cases of hepatitis A, where we had to provide vaccination in a school setting based on the advice of UK Health Security Agency. And there's quite a lot of things that we can learn from that, really, things that went well and things that need to be improved. So in Greg's team, we're facilitating the review of that plan, but it's obvious that many partners around the table will have a role potentially in implementing that. And one of our observations was, it's not just about the plan, it's about the degree to which people know the plan, it's embedded in their organisation, and they know what they're going to do when they're asked to enact it. So thank you to organisations who've nominated somebody to be part of that. I'll be coming back and feeding back to the Health and Wellbeing Board how we're getting on with updating that plan. And of course, one of the natures of the plan is that before you've even finished updating it, we of course might have to use it, and that's something that we are also incorporating into our learning, that we've got a plan in place, we're reviewing it, but we might have particular instances that we can continue to learn from in it. One of the issues in that as well is in relation to clarifying the funding, who pays if we have an outbreak or an incident we have to respond to, and because of the changing nature of the CCG signed up for the funding arrangements previously, so we're going to have to get agreement from the ICB about how we do that funding. Now, I'm conscious that I only had 10-minute items, so there were other things in the paper that related to the COVID public inquiry, and also about impacts of cost of living on, for example, food takeaway businesses and the quality of what they provide. I'm happy to answer questions on that as well if you want, but I thought I might pause there to allow people to ask questions on what I've said so far, or any discussion that you want to have.
Thanks, Ruth, and thanks in particular for that update on Strep A. Very much appreciate it. I've got David.
Yeah, thank you. I suppose it goes without saying that childhood vaccination immunisation is the most important health intervention that is delivered. There isn't anything more effective and important. And it is concerning to see that some practices are delivering less than 90%. How effective do you think NHS England, as the commissioner of these services, in tackling that? And from my previous experience, it's really about targeting the practices and ensuring that they're offering the appointments, that everybody's giving a consistent message, that no child who isn't vaccinated can get out of the practice without being vaccinated unless they really object. All that sort of stuff that helps to drive up those rates, because whilst it's plotted against deprivation, you can see practices that I imagine have very deprived catchments that achieve excellent coverage and vice versa. So I think my question is, how effective do you think that NHS England is in doing that work? Because I think they have the main responsibility.
Yeah, so I'll say something about that, but I can also see that Lee wants to say something. Do you want to go in before me, or do you want me to say something first?
It depends what you're going to say, Ruth.
Okay, I'll have a try and then you can agree or disagree with me. Yes, NHS England are responsible, you're right, and colleagues, we do know that colleagues work to support GP practices to put in place things that are effective. We also know that it is really challenging, and we've got a lot of GP practices who are working really hard and yet aren't getting the uptake. I think that one of the things that we've worked really hard at in the public health team is making it really clear to NHS England that we expect them to consider inequalities in everything, that they're the commissioner, but they're the commissioner who's responsible for addressing those inequalities by the actions that they seek from who they commission, but also from the support that they give. And one of the things that we're really keen on as well is how they use the other bits of work they commission to support the childhood vaccination programme. So, for example, do the school-aged immunisation service look at, when they come to deliver adolescent IMS, do they look at those children and say, actually, you haven't had your final dose of measles? Can we give that to you right now as well? And that is what we would expect NHS England to be asking of their other providers, not just of primary care, because there's what primary care delivers, and then there is the how do we get ad hoc, which I know people don't like that word, but how do you get the making every contact count? Then how do you get that opportunity where you've got a young person in front of you to check that they are up to date with their IMS in a variety of different settings? I think that would be. I'm bated breath now. And Lee is going to say that you
very user-friendly, but we just have to understand the situation out there, don't we? So I sort of would challenge that there are some practices in very deprived areas doing excellently. When you drill down, the actual immunisation rates in some practices are as low as 56% for MMR, which is shocking. It's a long way off. So sort of as a city, we can do well, but actually individual communities, it's very, very different. And the significant change has been the way that the practices are paid to immunise the children. And as you know, it's changed, it's slightly complicated, but it means that basically, if you're working in an area of high deprivation with communities that are at greatest risk of having the communicable diseases that we're trying to immunise against, you're actually penalised for not being able to reach those communities in the same way. And it's not even that the practices aren't working as hard as they can and patients aren't as willing as they can be to come. The actual criteria that's set in place is physically not able to, you're not able to reach it if you've got people coming in new to the country. You just cannot hit those targets. And it's an all or nothing. You do get paid for item of service, so for each immunisation that you give, you get an item of payments, which is great, and we certainly would welcome that, of course. But there's the extra payments for hitting the targets, and that money is the money that pays for staff to contact the patients, to go out, to do the following up, to actually give the immunisation. So I did a bit of a sort of phone round of practices in the north where I predominantly work, and practices are losing £11,000 a year, £13,000 a year. That pays for people to do this work. And obviously the practices can't afford to fund that for nothing, because these are also the practices that are very, very busy because of all the multimorbidity and extra disease that exists in these communities as well. So it just will mean that extra work of following up and reaching into communities will not be happening, and therefore the risk is huge. And from a public health point of view, that's a massive risk to the rest of the population. So I know that we've written to NHS England. I know that we're looking at what we do. Absolutely would welcome all partners who come into contact with these children to do all that they can to immunise. But I think there is a huge issue about the funding of the mainstay of the immunisation, which is in primary care. And we can't afford to do nothing because it will only be getting worse.
Yeah, and also just to say that I deliberately chose the map which is about diphtheria containing vaccine, because we've had a vaccination programme in this country for diphtheria for 80 years, and it's a very effective vaccination programme. But we've seen in the news that diphtheria it still exists as a disease. There is still a risk from diphtheria in some of our most vulnerable communities, and therefore keeping vaccination rates high for something like diphtheria is so important. And that's why I chose that one particularly to put as a map.
Thank you. I'm just conscious of time. I have Daniel, Greg and Helen in that order.
Okay, so this kind of connects, I think, to something that Emma said earlier, but I was just reflecting the fact that the last meeting of this board, we had a paper on the experience of the COVID vaccination programme and the importance of community engagement as part of that, and in particular in supporting us to do particularly well as a place. And I'm just wondering what lessons there are from that that can be applied here.
Yeah, and I would say that colleagues from NHS England and the public health colleagues that support NHS England, who used to be in PHE supporting NHS England, are really working hard to engage with particular communities based on the lessons from COVID. So, for example, doing some work in a secondary school with groups of young people who are particularly have got a number of questions about vaccination, to work with them and to understand what the needs of that community might be. I think the other thing to say, which is brilliant, is that some of the lessons we learned from COVID have actually changed how some services have delivered in relation to vaccination, not childhood vaccination, in the sense that the Moor Market Store, which was really popular and met the needs of people who weren't going other places, still running, still delivering COVID vaccination, supported by STH delivering that. So we've actually also broadened the understanding of some organisations about where they can go to deliver vaccination. Now, that's not childhood IMS, but that is learning some of the lessons from COVID. I think we've also got quite a complicated picture following COVID vaccination, actually, because we're seeing that some people have almost got fed up with being vaccinated. So when you've got a vaccine that you need every year, like seasonal flu, and some of the COVID boosters, people are, oh, I've had enough of being vaccinated, actually, and that is affecting uptake in adults. But we've still got, but the points that Lee made about children still stand, really. But learning the lessons from COVID, that is about different ways of delivery, and it is about engaging communities, and some of that has been learned, but we definitely need to keep that ongoing, I would say.
Still on vaccination, to answer David's question directly, credit to NHS England team who've worked really hard with practices. They've done an amazing job, actually. And ditto credit to the STH Children's Hospital team, and credit to practices. The deal breaker in this was always the funding mechanism, putting this into the routine QOF. That was always the deal breaker. Being blunt, a number of people said this would happen about a year ago, and it has happened. And that's the main deal breaker. And as Lee said, that plays out in less resource for practices to do the things that would get vaccination higher. And Ruth's made the point on the lessons of COVID, so I won't repeat that. Building that into routine commissioning and routine delivery is the deal.
Helen?
Yeah, I think actually Don stole my thunder. I think it is really important to think about what we know and what our strengths are, because we've got a track record, haven't we? But just interested in what other insight we've got. I mean, obviously there are some like funding structural barriers or challenges, but have we got a good insight on the communities and the kind of nuance behind why people are not engaging? It sounds like you've already been doing a lot of thinking about this.
Yeah, and NHS colleagues are doing a lot of this, and we're pushing them to always be considering inequalities, and we think that we've made that point strongly and that they've accepted that. I think it would be fair to say that we're stronger on geographical inequalities than inequalities related to other protected characteristics where the data might not be so strong. And I think that's where both looking at the data in different ways, but also some of the insight work, like the work I was talking about that they're doing, particularly in secondary schools, are both important to get that understanding of what interventions might work to support people to take up vaccination. Yeah.
Just taking one last comment from Emma.
Thank you. Yeah, I mean, I think there's obviously two parts to this. One is the uptake and learning lessons from COVID, but the other is the funding issue. And we can't let that get in the way of doing this. It really is fundamental. not only as a health protection issue, but actually to those children. So we have had some discussions with NHS England. I'll be following that up, and you know, potentially we may need to look for a local solution to this, because we can't let these children down. So so it is high on our agenda, and as Greg said, and you know, we are aware of it's an ICB, and we are in discussions with NHS England around this. But we have to do something different to ensure that we don't leave children behind.
Very quickly, before we do move on, two quick things just to know. Ruth alluded to the mass vaccination treatment plan. I'm going to be writing to Gavin on behalf of all 4 of the DPH in the not too distant. I'll copy you, Emma. We'll get to test that again before we've agreed to the plan. We always muck in, we always do the necessary, but it's never quite sustainable. Antibiotic prophylaxis for school group scarlet fever may well happen next week. It may well happen in 2 weeks' time. It's those kinds of scenarios that crop up that we do need to kind of have probably a more robust plan. One point that Ruth didn't mention, I'll just get it down on the record. One of the messy spaces here is investment in community infection prevention and control. We do underinvest in that in Sheffield, with Ruth and I working on that. I don't know the answer because I haven't got the resources, but it is a messy and under-resourced space, and it's actually quite risky.
Thank you. Thanks, Ruth. There are some recommendations that come with this report. They are on page 10 of your pack. The board are recommended to note the key protection issues, including the impact of winter pressure and cost of living, support increased uptake of immunisation, ensure the organisation is engaged with review of the mass treatment and vaccination plan, and work to embed that into partner organisations, and continue to support cross-system learning from COVID-19, including contributing to and learning from the UK public inquiry. Are people happy to accept those recommendations? Thank you. We are moving to the next item, which is the Better Care Fund update. We are 15 minutes behind schedule, so if we can talk faster. Thank you.
So I'm very happy to go and do that. So the Better Care Fund report, if we could speak to this one today. This report is for noting only, and it's a copy of the papers that was endorsed at the Adult Health and Social Care Policy Committee on the 16th of November. And that includes the report and all the appendixes. And in a succinct summary about the Better Care Fund, there's often many questions about what the fund is, how it's used, and what its purpose is. And essentially, what the reports do is give that very much that summary of exactly that questions that are often asked by me and by the public, you know, and so essentially that's what it gives the breakdown for. It also sets out what the government requirements are around Better Care Fund, and which we're required to meet, along with the key local targets that we're also required to go and meet. And essentially, the key plans, which is in the appendixes, which is both the 22-23 plan and the annual report, are basically plans that have been endorsed by the Health and Wellbeing Board previously. So they are no news, basically. But I would say fundamental to all this, and I think which is really important to me, is that actually what's really important in all this is the underpinning culture that we're trying to create through the Better Care Fund. What this is about joined up working between health and care to ultimately to improve the lives and outcomes for people. And you know, that's ultimately the essence behind us. And for me, what's been really important as we've worked over the last couple of years through the Better Care Fund and tried to implement this in a really positive way, is actually that building of the relationships, using it to get the best outcomes for people, but ultimately creating that culture of really good joined up working, but also not just about cross agencies, but fundamentally with people. That's what's been really important through all of this. And so that's what I'm going to say, and keep it very brief. Any questions? No.
Yes, I note that the delayed discharges is a required metric, and obviously in the hospital, in hospital provision, we're very anxious about the very large number of patients whose discharges are delayed and all the impact that has on providing effective and timely acute care and elective care. Have we set a target for how we expect that number to fall with the addition through this application of the Better Care Fund, or is it not a target, just something we're going to watch? What's the plan?
So there's two sets of funding around the Better Care Fund. This paper sets out what is the continuous funding that's provided across both the Better Care Fund and the Section 75 agreement. And essentially within the paper sets out the 4 key targets that relates to delayed discharges and more crucially for me, which is obviously my point, is prevention of admission to hospital. And that sets out the targets, and actually the last Health and Wellbeing Board, we actually gave an update against the progress against these targets, which are also included within the appendixes. So that metric is measured through the continued funding. What I think you may be referring to is the new funding that's been issued by government, which is short-term funding that has another set of targets that's been set separately by government, and that's a separate set of papers and information that we're currently working on just now as to how we respond to that. The criteria for the new funding that has been issued has just been issued quite formally over the last week. So literally we are having to respond to that. So this paper only gives the information about the current and ongoing funding, not the new funding. Okay. That makes sense.
Yes, Sharon.
Hi, I'm not as close to this as obviously there's a lot of information here, but could we just make it clear when we're talking about delayed discharges, particularly with the new funding, whether it includes mental health, because we have the same issue in mental health as we do in acute services?
Thanks, Alex.
Yeah, I think it's a really good point, and certainly from my point of view is, and I'm going to state this for the record because I continue to state this one, for me what's really important, and when we talk about people returning home from hospital well, I personally tend to use that as more the term rather than, because I think this is about keeping that about people. And for me, my perspective in coming into Sheffield has always been about, it's actually not about whether it's about the trusts, it's actually about people, and whether people are experiencing mental health, ill health, or have a learning disability, or are older adults, or are children in fact. What's really important is that no matter who the person is, they should be able to return home from hospital and well, and ultimately shouldn't have long stays in hospital. And certainly, you know, yesterday at the Health Scrutiny Committee as both colleagues from the Sheffield Health and Social Care Trust and myself presented around the paper of the changes to First All Rise, which very much focused on the changing culture towards prevention of admission in hospital, which was really, to me, in the spirit of what the Better Care Fund was all about. And I think that was, to me, was a huge step forward in how we work differently and work well together to go and ultimately improve lives and outcomes for people. But certainly for me, and I think, you know, just to give that absolute assurances, for me it's about people, no matter if it be young people, people with a learning disability, or people experiencing mental health, or older adults. It's really important, and no matter who the person is and their families, that they are assured that people could run home from hospital and well. And that's my commitment.
Hello.
Thank you, Alexis. It's really helpful to see it set out. I guess I've got a question about, because we have this conversation year in, year out about how we manage some of the targets that, you know, that are really tricky as a city and in other places. But I'm just interested in, what do we actually know? Because we make an assumption that around some stuff, I think we know some stuff. I think there are a lot of people who've got insights that we bring to this, but I'm not quite sure that we've ever said, actually, we've got a really good set of intelligence and understanding about what we do as a city to support a kind of more holistic response to people's needs. And it's that point that Emma's made quite a few times, which is, let's start from the person and then think, actually, let's build something around that. And I just feel like we need to do something that brings a really good insight that identifies maybe 3 or 4 key groups of people that we're just going to really focus on in terms of their needs starting from then. Because I think we often talk about how we get people out of hospital, and we don't talk about how we keep people in the home in a way that, you know, is really sort of informed by a range of views.
I think it's a really good point, and certainly for me, it's that one of the core questions sort of coming into you know, over the last couple of years is that, for me, what often happens is the government sets a fund with a set of targets that we have to go and meet. And in some ways, what this does is really simply sets out, in a sense, what we have to work towards. But I think for me, what's been really important is to look at this as more of as an opportunity for test for change. And one of the key things in taking this report to our committee was to kind of do that scene setter about, this is the information here, but actually how can we use this as a cultural change piece to look at exactly that, is how do we fundamentally re-look at how we're working with people in the city. And there's a number of kind of helpful things in place within that. We've got, number one is the change programme that we've talked about within adult social care, in which is about actually how do we enable people to live more independently at home, which is always my kind of perspective. Secondly, what we've also got, as I think the colleagues in health here, is what's called the Nurturing Care Board. And that's really shifting the culture about how do we actually work in a very different way and get the data intelligence across the health systems and social care systems and whatnot to really go and get exactly that intelligence and that joined up ways of working. And I think that's a really helpful step forward. And then sort of third for me is about the kind of partnership and how we work together to improve outcomes for people. And I think there are, and I'm going to say this in a really positive ways, I think that there's a lot of conditions that's now in place in Sheffield that I think will help us to move forward in a really positive way. And I think what we've got is some good foundations in terms of how we join up in terms of our funding, join up in terms of our partnerships, to then go and say for 23-24 and going forward, how do we bring that together to get the best outcomes for people?
I have Zach.
Thank you. We're in the right place to have this conversation because it's got to be a shift towards well-being. I'm sick of being an illness practitioner and I'm failing because we just can't. We don't have the capacity to do it. It's back to that conversation about complex patients. I'd love to have the time, and some of that is there. Some of the little building blocks are there. The evidence, however we cut it, we've been doing it for the last 20 years, 25 years. Around a third of the patients who are admitted to hospital don't need a hospital level of care. The frustration out there as a practitioner working in the community is you've often got patients that you're managing really well. You've got really clear plans and you just don't quite have the support that actually stops the crisis, which then leads to the admission. And once the patient's in, decompensate really quickly. It's appalling because you've got individuals, quite often elderly individuals, close to the end of life who are managing and have a good quality of life within the community who end up being hospitalised for the last stage of their life. I mean, it really is. It's horrendous to see. So we do need to get a shift. And again, we're pushing against the tide because there is an obsession with individual targets. We've got to look at the whole pathway. So the way to avoid a discharge is to avoid the admission in the first place. And that's not that you want to actually cut costs. It's better care for the patient. The patient should not be in a setting that the patient doesn't need to be in for that individual, but also for the fact that then stops the care that can be delivered to the individuals that really need it. So we've got all the evidence. I'm happy to share it with you. We've got an interqual audit we did 10, 12 years ago. We've got public health reviews where we look at what capacity you need in each part of the system to manage the care for patients. But it's got to be a movement towards, and some of that's a challenge to clinicians, to start to move away from the medical model towards supporting the wellbeing type approach, which is hugely satisfying if you can get the time to do it. And that is also the bit that will keep clinicians within our system, because at the moment just rattling through people who are ill and trying to just get through them like an illness factory is not particularly satisfying. And I think if we can get back to that wellness, so the Health and Wellbeing Board, we talked about this years ago, maybe this should be the Wellbeing Board where health sits underneath it. It's got to be the way that we do it.
A last comment from Alexis before we move.
Just to get me following what Zach's saying is that one of the key reports actually was, and for me one of the most fundamental reports on the 16th of November is alongside this that was endorsed by members were future design of adult social care. And what that really set out was joined up working between primary care and social care around how we enable people to work closely, together in the community to ultimately to enable people to live independently at home. And I think one of the key things that we're doing from that is developing joined up teams with colleagues in the voluntary sector, primary care and social care. And I think if we could really build upon that as a city and have that joined up and around that joined up working, what that then does is it means exactly what Zach's talking about. is that we're not focusing on so much the question of how we enable people to return home from hospital when well. What we're focusing on about is actually how we're enabling people to remain in their own home and live independent and good lives. And that really has got to be the focus. And for me, that is absolutely my ambition I want to put into this, is how we just reverse the conversation, for want of a better word.
Thank you. We are asked to just note this report. Are people happy with that? Thank you. And we're moving on to item 7 on the agenda. Greg, I believe that's you.
Yeah, short paper, and I'll be short with it. This is on Health and Wellbeing Board co-chairing. It's a follow-on from last meeting, I think it was. The key points: historically, the board's been well served by an NHS local authority joint chair. The shift in the NHS hasn't yet bedded down, but that means we needed to review that. There was a fairly lengthy discussion at the last meeting. We went away to explore options. The proposal in the paper is that the ICB Medical Director for Sheffield, aka Zach, it becomes the co-chair of the Health and Wellbeing Board. We'd need to amend the terms of reference and recommend those to Council in due course, but that's basically the nub of the paper.
Thank you. So there are some recommendations on page 136 of your report. Agreed that the chairing of the board will be shared between the chair of the Sheffield City Council Adult Health and Social Care Policy Committee and the medical director of Sheffield Police, South Yorkshire Integrated Care Board. That this arrangement will be reviewed whenever there is a change in personnel, if relevant, in the relevant roles, and propose necessary changes to the board terms of reference for full council to be approved as soon as possible, basically at the next opportunity, which I believe will be January or February. February. Thank you, Jason. And thank you to Zach for agreeing to co-chair with me at the moment, and then we'll see what happens next year. Are people happy to take those recommendations? Can I say thank you very much to the steering group for all the work on this, because there were lengthy discussions in last meeting and out of the meeting, so thank you, and welcome on board, Zach. Moving on to item 8. Greg, is that you again?
Yeah, so whilst Debbie and Debbie get set up, the paper is on oral health. I don't know if they're doing a presentation or not. Credit to the team, an immense amount of work went into this paper. Oral health isn't one of our beautiful areas, outcome-wise. We don't do terribly well in Sheffield, actually. We'll focus on the whole of oral health, dentistry and oral health promotion, and I'll hand over to Debbie and Debbie, who will take us through the paper.
Okay, so I'm here from NHS England, Debbie Stover. I'm one of the commissioner managers at NHS England, and I think we're just going to give you a bit of background. I don't know if that's working. That one. Oh, okay, sorry. Oh, too far. No, I've gone too far. Okay. So as you're probably aware, the population of Sheffield does experience high levels of poor oral health, and what NHSE's responsibility is in terms of commissioning dental treatment in Sheffield and wider for Yorkshire and Humber within the team I work in. We commission several aspects of dental treatment: primary care, which is your general high street dentistry, which is direct access. And the addition for that, I suppose, in Sheffield is that we have actually got a residential oral care service in Sheffield, which has been historic, probably back from primary care trust days, within care homes, which a lot of other areas don't have, certainly in Yorkshire and Humber. So we're actually quite beneficial to have that, and that's provided by a number of our Sheffield high street dentist practices, who then provide screening and for all home care residents and follow-up treatment where necessary. Community dental services by referral, that's for the more vulnerable residents and patients in Sheffield. Orthodontics, again, that's referral from a dentist, that's specialist orthodontic treatment. We do have specialist orthodontics. We do still have a few practices who actually provide general dentistry and orthodontics, but they're gradually reducing, so we've actually got specialist orthodontic treatment in the area. Intermediate minor oral surgery, that's referral from a dentist. That's where the more complex needs of patients, but not necessarily complex enough to need to go to secondary care, and that's provided by dentists that have got more experience in oral surgery. Urgent care via NHS 111, however, we've got a number of practices in primary care that also provide urgent care. And then secondary care, which is by referral only. Obviously for Sheffield, that's Sheffield Care, Sheffield Trust and Children's. And then the All Health Improvement Programmes are actually commissioned by Sheffield City Council. So we're going to cover just a sort of information across all these aspects, but just to try and briefly, because I know we've provided a very detailed paper for you. So we have across Yorkshire and Humber undertaken an all health needs assessment, and that was completed early this year by our dental public health colleagues, who did a really good piece of work. That's actually been broken down now into ICB areas, and then we've also now developing local profiles for each of our local authority areas. So there is one for Sheffield, and that piece of work helps us then sort of direct our commissioning and understand the needs in each of our areas. Just a little bit in terms of Sheffield. Tooth decay is progressive disease. It's largely preventable. Obviously, we need the preventative programmes in place and working with colleagues and local authority. Just a few high points we wanted to raise really. Age 3, we have got 14.7% of children in Yorkshire Humber were found to be experiencing tooth decay, but actually for Sheffield, by the time they're age 5, that's 41% of children in Sheffield. That's not dissimilar to a lot of areas across Yorkshire and Humber. But Sheffield does have the higher levels of tooth decay than seen in other parts of Yorkshire, in South Yorkshire. Tooth extractions are the commonest reasons for children to attend hospital, and we do commission those services with Sheffield Teaching Hospital, work very closely with Sheffield Children's Hospital in terms of theatre space for children. GA for children, so general anaesthetics for children, is one of our high priorities across Yorkshire and Humber at the minute. We have got a huge waiting list in some areas. I don't think they're quite as high in Sheffield, but it is something we need to be addressing. Key challenges that we're dealing with at the minute for dental access, as you all have heard probably numerous times in the news regarding access for dental treatment. It's been on the news quite a few times. It is our biggest area at the minute that we're actually trying to work with people waiting for access for regular care into dentistry, often on long lists. So our dentists are reporting they've got waiting lists in most practices. Some are actually trying to work through that and make sure we've got access for patients, but it is one of our biggest challenges at the minute. That's also compounded by availability of workforce. That's not just dentists, but the wider workforce within dental, so dental nurses and other members of clinical teams. The contract is also a bit of a challenge. We have just had the initial reform announced in the summer of this year, so we are still working through some of those parts in there, but some of them do require regulatory change, so we are seeing them the changes coming through periodically. And obviously the impact of COVID did have an effect massively on dental, where high street dentists were shut for about 3 months at the beginning, which has just compounded. And then they ended up with being able to do reduced activity all through until July of this year, when they're actually now expected to do 100% of their contract. But it is still a really big challenge and has created the backlogs. There's some perceptions of dental services. So people do expect that they're registered with a dentist. That is not true. They don't register like you do with a GP. Dentists are only committed to deliver a course of treatment to an individual, although many dentists do keep a regular list of patients if they're continuing to engage with them. They think it's free at point of delivery. It isn't for the majority of people who are not, but it is subsidised by the NHS. Some people do get exemptions on different benefits, etc., but there is charges for the majority of people. Practices accepting new patients for regular dental care. There is a site on www.nhs.uk which people can go on to find where dentists are in their areas. Ideally, we want on there for practices to be able to sort of say if they are currently open to accept people, and if they're not, what their weights are. It's not very flexible at the minute for them to be able to put the amount of information we want to do on there, but they are responsible for keeping that up to date with the flexibility they do have, although there are some changes as part of the dental contract reform that will mean that they'll be able to have a bit more flexibility than they do now. So we don't have in NHS England a list of practices to say who is accepting referrals and who isn't, and what their waiting lists are. We don't have that. That's a practice responsibility. Private dental care, many practices will have probably a joint private facility and NHS contracts, and that is purely up to them. They are independent contractors and they're at liberty to do that. Don't recognise that slide. Oh, because it's gone in a bit pretty rather than bullets. Apologies. So we've got some initiatives to strengthen and improve access to dentistry. So we are looking at other transformational commissioning approaches. So we have got flexible commissioning, which means that practices have got a bit of flex within their contracts, so it's not all focused on delivering what we call units of dental activity, but they've actually got some flex in their budget to allow them to have a more flexible workforce. So they're able to just, I suppose, work a bit differently within the practice to make sure they can meet the needs. And that's a scheme that we've got running in a number of practices. We've got 21 currently in Sheffield, and we've got hopefully a further 7 that are due to start in the next few months. And it allows them to have that skill mix and meet their own demands in the area. And that also means that they've got all health champions. They're able to work closely and have pathways with our community dental services to receive referrals to them once they're actually deemed as dentally fit, and also work with health and social care colleagues, so health visitors, social workers, when they're working with children and families. If they've got they clinically need some dental treatment, they're able to refer through to these number of practices we've got, rather than them just having to go on a general waiting list. So we've got some better pathways running for that. We've also had a number of practices run in what we've called an access programme, so we've commissioned them differently, and it's allowed them to meet the needs of more high-risk patients. That was on a fixed basis, and that is due to come to an end at the end of March. However, we are looking at how we can integrate that with a flexible commissioning approach. So we've had 10 practices in Sheffield as part of that, and it's gone well. We've reviewed it, and we've expanded it until the end of March next year. However, it's not ideal, and we need to make sure we've got a fair and equitable spread, and look at how we can do things differently. Again, using our oral health needs assessment findings. We've got some additional sessions currently running, and we had some at the end of last year, which was part of a national scheme. We've got some additional ones running at the minute until the end of March. And we've got a number of practices who have taken up the opportunity, so we're paying them on a sessional basis. Again, it's looking at urgent needs of patients, working with 111 in some instances, but also for the practice to be able to have a bit more flexibility and work additional to what they're already contracted to do, to deal with people with urgent needs or perceived urgent needs. And so that'll enable patients to ring a practice and actually hopefully be able to get an appointment, rather than just say, we'll have to put you on a waiting list, or just ring 111. Gives us some more spread across the area. We're currently also doing an initiative to validate waiting lists. As I mentioned earlier, we've got huge waiting lists in a lot of practices. So the piece of work going on with our public health colleagues to work with the practices to do some validation on that. So that's literally just started, and it's just been piloted. We've got an incentive to support practices to hopefully address the workforce issue. We've targeted that on high needs areas, and we've got a list of those. Sheffield is included in that in quite a number of the ward areas. We've termed it as a golden hello. So basically it's to hopefully add some incentives for those practices to try and encourage dentists to actually come and work in those areas, and stay with them for 2-3 years at least. We have been undertaking a review of the community dental services, and that's ongoing at the minute, and that should hopefully be ended at the autumn 2023. And as I mentioned, we've got the dental system reforms that are ongoing. Over to you.
Thanks. So I'm Debbie Hanson, Health Improvement Principal in the Public Health Team in the City Council, lead on the oral health promotion programmes. So we are currently in the process of updating the oral health promotion strategy. The last one kind of was up until 2022, so we're just finalising that. We have over 95 toothbrushing clubs in nurseries and early years settings, which reaches about 7,000 children across the city. The oral health packs, so toothbrushes, feeding cups, etc., are given out by health visitors to all families at the 9 to 12 month mandated review, and again to targeted families at 2. Oral health is included in the the Sheffield Healthy Child Programme, so all professionals working with children and families do discuss oral health at any opportunity. We do offer oral health training to really all staff that work with children and families, so early years practitioners, staff in health and social care, in schools and education, and also in care homes for older adults, and also children's residential settings. So, but it is offered to anybody that kind of wants it. There are links to other health initiatives, so Stop Smoking Services. Healthy Early Years Award is a bit like the Healthy Schools for early years settings, and there is a section there on oral health, and we do expect them to have a toothbrushing club as well to achieve that award, and the Sheffield Sweet Enough campaign, which is around kind of reducing sugar intake. Mini Mouth Matters is a programme in the Children's Hospital, engaging with staff in there to encourage oral health and children to brush their teeth whilst they're in hospital. And some of the statistics that you've just seen previously comes from the Oral Health Survey. So across South Yorkshire we commissioned the Oral Health Survey. Last year it was for 5-year-olds, this year it's for Y6. So a random sample of Y6 children are surveyed each year. And we're also, with South Yorkshire colleagues, investigating the feasibility of water fluoridation. So working with Yorkshire Water on that.
Okay, and then just finally, what needs to happen really, working together. We do have obviously links in with local authority and other stakeholders. We're working very closely with ICBs as well at the minute. Dental system reforms, we've had the initial stages of that in the summer. There will be more changes to come which are being dealt with nationally. Commitment to further engagement, we are committed to working with stakeholders, NHS England, and members of the public. That includes agencies such as Healthwatch. We've just recently expanded our South Yorkshire local dental network, where we have a whole network meeting, included that in Healthwatch. So we've got the first meeting which Healthwatch will be part of tonight, which will be interesting, and then we've just continued to develop the oral health improvement programmes. Any questions?
Thank you so much. Yeah, there are some people who want to ask questions. I'll take Lee and then Judy.
Thank you for this report. I suppose it's not really a question, it's just an observation, and I absolutely appreciate that it's a really difficult area to be in, and partly that's about staffing, partly it's about ways of practicing, I think, as well. I mean, it's always quite interesting. I'm not even sure if I'm allowed to say this, but I will. Coming out of the pandemic, obviously my dentist didn't see people face to face, but then there was that sort of funny period where they couldn't see you face to face if you're an NHS patient, but they could if you were private. And clinically, I was thinking, I'm not quite sure understand that. But anyway, so there's slightly different rules that seem to apply in dentistry to the rest of healthcare. Just to sort of give an example of what it's like. So most days, the practice I work in is serving an area of high deprivation, poor dental access, terrible oral hygiene, and most days we will have patients contacting us as GPs to get some treatment for their dental abscesses or dental infections or mouth disease, because they cannot get access to dentists, and on average they're usually told the waiting list is about 2 years, and that's consistent, yeah. And which just is not a service. So, and it is having an impact on physical, other physical health, obviously in primary care. So it is a huge, huge problem. And I understand that you're doing your best, but I'm not sure what the answer is. And I'd be quite interested to see what the uptake is in terms of recruitment and golden hellos, and to see if it does attract people, particularly to the areas of greatest need.
Yeah. We had I think we've invited about 20 or 22 practices in Sheffield to be part of that scheme. We're just at the minute reviewing those and about ready to go out with prior approval to the practices, because obviously it's about the practice being able to recruit using that as an incentive, because it's basically a payment that'll go to the dentist. So it's whether or not they can actually encourage people to come and work in some of those more deprived areas. Obviously, some of our dentists are independent dentists, so they're not currently have not been able to offer maybe those incentives that maybe your corporates will have been able to do. But I know even some of the corporates have offered enhanced packages and still struggled. It is a challenge, but it's just another way we are trying to support the practices to be able to attract people to come and work in some of those areas. So we have targeted that on the high deprived areas, and there's a couple of other ones in terms of our local intelligence. But Sheffield has got I haven't got the details, but we've got quite a wide coverage of the wards in Sheffield as a local authority. So we are I'm hopeful that anybody that has applied, I don't think there's any reason why at the minute we've looked to turn anybody down. We might have just queried a few things, but we will be sending that prior approval out hopefully in the next couple of days.
And if there isn't a good uptake in terms of recruiting people via that means, what's your feeling for how the next 2 years is going to be looking for dental services in Sheffield?
I don't know, to be honest, at the minute. The workforce is a real issue. It is a real issue, and that is a lot of the noise that we're getting from practices. They are working full pelt. With that, they have, as you know, through COVID experienced they've had a lot of demands on them and not been able to work as much as they could because of the aerosol generating and all that sort of thing. They're now back at 100%, but some are reporting that they are physically worn out. They're asking them to do additional, which is what we've been asking them at the minute. A lot are taking that up. I think across Yorkshire and Humber we had about 115, 120 practices interested in doing that. But that's on top of their normal activity. So it is a challenge for them, and they are trying to do their best. The waiting list initiative will hopefully give us a better indicator about what the true wait is, because I expect we've got, Mary on a waiting list at probably a dozen practices in Sheffield rather than just one. So hopefully it'll give us a better indication about what the waiting list situation is. But anybody that's in pain should ring NHS 111. They do. But the additional sessions are also going to take some of that weight off NHS 111 as well.
Sorry, I know we could talk about this a lot, couldn't we? Because we must bear in mind that this was a problem pre-COVID, and we often put everything down to COVID, don't we? It was an issue, and it's all part of that wider NHS workforce issue, isn't it? And I think we just go, oh yeah, workforce, oh it's difficult, but actually these are people's lives, they're in pain, it affects their health. We do sick notes because people can't get to work, it's impacting, and it's a huge impact on secondary care as well, in terms of, the commonest cause for a child being admitted for surgery is for dental caries.
That's awful.
Thank you. I have Judy and Emma, and I'm going to close it after that.
It's really good to have the focus on this area of work, particularly dentistry, because as you know, Healthwatch has been a broken record on this. It's still a current issue on our feedback, and although it's true about waiting lists, we get feedback that people can't even go on waiting lists. Also, a couple of things around pregnant women not getting access to services, and 111 at the weekend. And I think we perhaps were talking to you or the Commissioner about availability of emergency services, only available 9 till 1, but nobody knew that. So I think I'd draw a couple of things. It's still an ongoing issue, but a couple of points. I think the lack of up-to-date information is really difficult, that people just don't know how to navigate the system, and that really could do to be improved. Now, I wonder if that's something that NHS England could do. And the other one, I really welcome the meetings with Healthwatch. I have to say it has been really difficult over the last 3 years to have a conversation, to find out who the Commissioner was and have a conversation. But it seems to me that patient feedback and feedback from voice organisations is really critical, so that you've got the really current information about what's going on and what people need.
Yeah.
So I hope that goes well, and we'll look forward to hearing about it.
Yeah, thank you.
Emma.
Thank Thank you. Yeah, 3 quick points. One is the Dentistry Commission is coming back to integrated care boards from April, so we will be receiving this back. 2 issues. One is workforce, as you already mentioned. And can you just confirm how many practices in Sheffield are actually taking any new patients at the moment?
I can't tell you.
You can't? No. Okay. Oh, so that's a real issue. The second is just around the contract and system reform. The current contract as it stands will not help. So again, I know there's some work going on that, but anything we can do to influence that, and I know there's some of our local politicians really interested that if we can help in any way, please let us know, because that will not help the problems we've got. And the third issue is just around how many children in Sheffield do you think own a toothbrush? You know, in terms of oral health and oral prevention, you know, I've worked in deprived cities where we've done work with schools just around getting children to brush their teeth, you know, in school. I know then COVID happened, but actually, in fact, but there are some other things we can do around prevention upstream that might help that the voluntary sector, the community sector might be able to help with. So I know there's no quick fix to this, and we'll be taking it on and obviously doing what we can, but anything we can do to try and prevent, you know, children particularly, you know, getting into a cycle of having to have, you know, fillings, etc. at an early age, we will try and support. So just 3 observations for me, thanks.
Thanks. I'll just pass it up to Greg very quickly.
Thanks. Two thoughts on the prevention aspect of this. One, Debbie talked eloquently about problems with access and well-trod territory. We won't solve these problems by investing in more treatment. It's like saying the problem that will solve cardiovascular mortality by more cardiology wards. It's kind of that analogy. So I'll talk maybe not eloquently about left shift. We spend £130,000 on oral health improvement in Sheffield. It's my responsibility. I know we grossly underfund that. We spend many tens of millions of pounds on treatment. So if we want more prevention, we need to invest in it. What we do have is really good, actually. I've zero doubt on that. I can't answer the question how many people own a toothbrush, sadly. It's worth the note, and it's briefly mentioned in the report, that work is nearly finished with Yorkshire Water on community water fluoridation schemes, the technical report that has been just about finished. Yorkshire Water need to send that to us, but basically the job was, is it technically doable? Where would one put plants and how much would that cost? That then is sent to the Secretary of State because the responsibility shifted to Secretary of State. But for what it's worth, on the basis of the evidence, I would still wholeheartedly recommend such a thing. I'm aware it's contentious in many people's minds.
Thank you. There are 2 recommendations from this report. Number 1, ensure that the Health and Wellbeing Board continues to support the water fluoridation agenda in South Yorkshire. And number 2, ensure that oral health is mentioned in the Sheffield Health and Wellbeing Strategy. Are people happy with those recommendations? Brilliant. Thank you. And we're moving on to item 9. I'm not 100% sure who's presenting this one. It's the learning disability update.
Switched on. Good morning, colleagues. I'm Heather Burns, Deputy Director of the Mental Health team within NHS Sheffield, and we cover learning disability, mental health, autism, dementia within that team. And today I'm coming to talk to you about some work that members of my team have been doing for quite some time. They couldn't be here today, so work of Liz Took and Anita Winter on the LEADER programme. Now, we came to you back in January 22 and you asked us to do an update, which we did to you in July 22. And this is just a further update that you asked us to come back for. So at that time, you were asking us for a steer on what health and wellbeing partners could do. And I think what we said to you is to help us and get behind the physical health strategy that we have across the city. And that strategy is aiming to improve access to healthcare for people with learning disabilities and to help to reduce that mortality gap. Now, just to remind you, colleagues, that we're talking about an up to 28-year mortality gap for this population of preventable ill health. But I don't want to go over some of the facts and figures that we talked about back in January and June. What I will just draw out, though, having listened to the last presentation, is oral health amongst the population of people with learning disabilities particularly compromised. And it's associated with the cause of death. So the biggest cause of death for people with learning disability is respiratory illness and pneumonia in particular, and tooth decay can obviously be connected to that because of the high levels of oral bacteria that people have circulating in their system. But in terms of causes of death, certainly there are a number of things that are really quite shocking from the leader report. 12 people in this city died of constipation, and that's, I just find that astonishing to think about. But in terms of the other thing that you asked us to do, and why you've asked us to come back, is you asked us to make sure that we were co-producing our strategy. And this is just to give you a little bit of an update about that. So originally the strategy was co-produced. I don't seem to be moving. Yes. But we did go back and talk to Sheffield Voices over the summer and ask them for their experiences. What was really good is that we did hear of some positive experience of healthcare and that people have been treated well. And that often was around the reasonable adjustments that people put in. So changing appointments to have quieter appointment spaces, longer times, easy read materials and those sorts of things. But people were still describing a lack of understanding about their learning disability, and also increasingly autistic people are telling us that they really struggle to access healthcare. The sort of latest statistics on avoidable deaths of people with autism show that people are dying around 16 years younger of preventable health condition for that population. And that's for people without a learning disability, just purely on the autistic spectrum. So that kind of lack of understanding was coming out. And then just generally a lack of ability of professionals to communicate with people, and still people talking to carers and not involving people. Basic accessibility was also mentioned again. People having booked appointments in upstairs meeting rooms when there's no lift and they're in a wheelchair. And a recurrent theme around access to things like breast screening. If you're in a prone wheelchair, you can't access the scanners. So those kind of things, that's still challenges to people, and that's the things that we were hearing over the summer. A few sort of examples, and again, dentistry comes out in this, a bit of good practice around people using visors so that people could still lip read. Really simple things, but it made a difference to people. People talking about how kindness actually and empathy is a really important thing when they're interacting with services. And also people at local GP services being really good about getting to know the person on an individual basis. People are struggling though with the telephone system, even though that's kind of an improvement for many people. That's something that people with learning disabilities are struggling with. People talking about going into hospital and then it had really been difficult for them to be discharged, and their experience then becomes one of decompensating for some of the skills. So quite a mixed bag of some of the voices that we heard. I wanted to give you some good news on progress, and this, I'm really proud of this work that members of my team have done. So we've had 416 more people with a learning disability having an annual health check, and that's really thanks to the GPs in this city that have worked hard with us on increasing that. We've also increased the numbers of people that we've made eligible, and we're particularly working on people 14 upwards. So what I would say to my Sheffield Children's Hospital colleagues is please help us through your CAMS teams to encourage those populations of people with learning disabilities 14 upwards to get their annual health checks from the GPs, because we've not got as many younger people turning up for that. We've been delivering a lot of training across what's called the ECHO platform, and that ECHO platform is trying to train providers, social care providers and other health from, some of the learning from the leader work. And then we've had a 29% increase in access to breast screening for, bowel screening for people with learning disabilities, which is really positive. It's a within year progress, and also we're doing a similar project on breast screening. So those sort of access to screening programs are really important. Working on vaccination rates, I'm really proud again to say that people with learning disabilities and flu vaccine, we've actually had a higher rate than the rest of the population in terms of people accessing that. Again, things that people worked hard on. And then we've been really working hard on increasing access to people with autism for an annual health check. This is a national project that Sheffield is one of 5 national partners that are doing an annual health check pilot. So there'll be 100 people with autism that have an annual health check. So a lot of work that's been happening and a lot of progress that's been happening. But you asked us what could Health and Wellbeing Board do? And I think the challenge that we gave back in January and in July in our paper was saying, really, this isn't just about a small team of people working on a number of projects. We have got membership from most organisations in the physical health improvement group, but we really want to make organisations kind of accountable for that and for their contribution to how we as a city and as system partners can help people with a learning disability to access the services that we're providing. So we'd suggested that you might want to ask partner organisations to do an update to board annually about what they're achieving to improve access, because to get some traction on that mortality difference, to bring down that early morbidity, it's every single health and social care partner that's working in collaboration to do that, to make sure that access is improved, to make sure that our frontline staff understand the needs of this population and can make accommodations. And we'd also suggested that you might want to have a Health and Wellbeing Board sponsored Health and Equalities Champion. And that's come from people with learning disabilities and their families themselves kind of asking for that. So we're just presenting that to you as a board. And also, we've just had a conversation about dental health. I then told you that it was one of the causes of death for people with learning disability because of the link to respiratory. If every time you have a presentation, there was somebody that said, can you tell me how this applies to people with learning disability, we may just get some more traction. So that would be our final ask from the physical health group and the leader steering group in the city. Thank you.
Thank you. And it's great to see the progress that's been made, particularly regarding access. I think we've got to take up this challenge because that was July and we're now in December. And I think we really need to do it, whether it's initially through the partnership and then feeds in here, I don't know, but I think we need to do it. And I think we should take up the suggestion. We can't ask them what they want us to do and then not do it. But I think we really also need to focus on the experience as well as the access. The access is really important for the health things, but the experience, as you alluded to, is not always very good for these, people and their families. So I think as well as the access, I think let's not lose the experience piece of it as well. So thank you very much. Great to see the progress though, but I think as partners, we've really got to take this seriously and really answer that, that challenge that's been given to us. So thank you.
Thank you. Greg?
One thought, one question, well, two thoughts. One, I missed the 29% percentage point increase in bowel screening and flu COVID jab rates above the Sheffield average. Wow, genuinely, that's not clocked it, that's genuinely amazing effort. On your asks, the previous slide, I'd say yes to the annual update. We'll do that as part of the annual accountability framework, which Dan and I, steering group, are working through. But yeah, I think to take that as read. Broadly, I'd say yes to award. Ability to organise such a thing worries me a lot because we haven't got the kind of capacity to organise it. But in principle, yes, I'd go there. And then thirdly, on the sort of consistently asking all conversations that we have, what are we doing to close this particular gap? I'd say yes, absolutely. Just slight care, over-mechanising it, it becomes the box to tick without thinking it through really, really, really carefully. And people that write stuff and or present stuff need to think it through, not just tick the box.
Yes, I'd agree with that. And I think this is actually part of why a conversation like this is important, because it is to stimulate that, what can I do differently? And really, what can I do differently? And I think you're right, things like equality impact assessments are a start, but if they become a tick box. So yes, I'd welcome that further sort of conversation.
David and then Helen.
Thank you. I'm David Black, Medical Director of Development at Sheffield Teaching Hospitals, and my apologies for missing some of that. It's just my dad, who lives elsewhere, has just come out of hospital and things aren't going that smoothly.
Oh dear.
But I'm also the Trust Lead for Mental Health, Learning Disability and Autism. And so I just wanted to be sure that I'm still quite new at the Trust, but we have just been through the process to appoint 2 new members of staff for
Yes.
LD and autism, which I hope you're aware of.
I am, because you've pinched one of them from me.
Oh.
But I'm really pleased, actually, because that's a great connection with the work that we're doing. So
that's really positive. And we have a member of staff called Siobhan Brennan, who's successful in her application with support from the Trust to join the LD and autism. They call it a consultant development programme funded by HEE, so she's on that.
Right.
And she's chairing a new group in the Trust to develop an action plan so that we can improve care for patients with LD and autism. So I'm hoping these things together will make a real difference for how we look after patients with LD and autism, particularly because we have some audit data that shows that in things like using the passport, involving people with LD and autism in their care fully, hasn't been done as well as it could be. So I think we've got I think we've got a lot of commitment, but I think we've got quite a journey to get things as good as they can be. So I think it's really positive that the Trust wanted to do this and support additional investment. So it's good news, and good news in your report as well. And I'm sure that we should, as a Trust, if you can give us a little bit longer to kind of get people in post and so on, maybe in a few months, maybe 6 months' time, we could come and give an update on where we've got to in our work at the Trust.
That'd be really positive, David, and I really do appreciate that. So what we will do is we'll continue that connection with Becky, who's moving over from the Care Trust, but she'd been doing a piece of work for NHS Sheffield. So that's a great connection. She's already part of the physical health group. We'll invite Siobhan to be part of that, and we've had some fantastic support from your colleague Una Cunningham.
Una is the lead.
Yeah, and she's done some fantastic work, including the audit on health passports, which helped to see, there's some,
absolutely, and
more
Siobhan's
work.
working closely with doing that and giving us more capacity, which is what we needed. So
fantastic.
Thank you.
So that's a really positive piece of connection there that we can maintain. Thank you.
I have Helen, Lee, Alexis, Catherine and Emma.
Thanks, Heather. I think it's really, really important, and it's great that you've brought this and you've got that level of insight, because I think we need that, don't we? We need to be working at that level and understanding some really harrowing facts, actually, because we talk about the life differentials quite generally across the city, but this is just such an acute disadvantage and inequality. I think that there are some really good suggestions, and I support what you've brought here. I think that focus is really important, and having that shared accountability and reporting back. I think also it would be good to think about, where people actually get their support, and sometimes it's not through services, is it? I think bringing services to people in the places that are working and will have an impact. I think we've got some really good insight around that. And then the other point I wanted to make is we've not drawn out people who are not identified, particularly, autistic people who don't get identified for a number of reasons. And I think that's another layer that we need to start working on. And I know that there is some work being done in the city, but I think that needs to be quite explicit, particularly in racialised communities where people are hidden and not recognised at all.
Yes, thank you. And I think the pilot that we're involved in for 100 people having annual health checks will actually help to illustrate some of this, to say what are those kind of issues that people are facing in wider practices too. Thank you.
Lee?
Yeah, thanks, Heather. That was just a really great report, and just all those improvements that we've seen and benefits haven't just happened of late. So it's just, and I know all the partners have been involved, but I know that over the years you and your team have been driving this, and it's taken a lot of work to get to where we are. So just thank you for all you're doing.
It is a team effort, as you said.
Absolutely.
Multi-agency effort.
Yeah. So I suppose it's just an ask of us as a board to see if we can just up our expectations in terms of making sure that this isn't going to be a box-ticking exercise when we're sort of considering how is this going to impact on people with lived experience. Could we ask that we don't just think about it, but we actually ask the people with lived experience before we bring a strategy here? you know, it delays things, but I think increasingly as we're going forward as a system, we understand that co-production and public involvement is got to be the bedrock of all that we do. So, you know, not just to think about it and consider it with every strategy, but maybe to ask the people who it's going to be most effective by.
I just want to say thanks for the report. I think it's really good, and I think, do you know, I think what I think is really great about the step you're making is practical steps about how we improve health of individuals. And I think, you know, one of the key things my asks is that we have both the Autism Partnership Board and also the Learning Disabilities Partnership Board. And I think what you know, what I think would be really helpful is if we could just coordinate the actions through these boards, because so that what we don't have is lots of different action plans. What we have is one action plan. We're currently, I say that because we're in the moment just now developing the strategies for both for Autism Inclusive Sheffield and also the same for people with learning disability. And I think what would be really helpful if we ensure that we've got that connectivity across the city, and then that means then we're taking that joined up approach and we're seeing absolutely people as people, and we are ensuring that we are taking forward the actions in a very joined up way. And it's helpful to know is that I actually chair the Autism Partnership Board, which is why I've got an absolute vested interest in absolutely making sure that we really do have a joined up kind of response and going forward. Yeah. So thank you for that, Heather. And I know, can I just say, is I know the team here have done a huge amount of work behind the scenes and are so passionate about making improvements.
Thank you. And we do have members of the Autism Partnership Board on the Physical Health Improvement Group, which is, and they're experts by experience, family carers, which is fantastic, and a learning disabled person too. So it is important to make those connections. Thank you for the reminder about that.
Catherine, Emma and Judy, and I'll close it after that.
Yeah, thank you, Heather. Really good report and amazing progress. It's great to see. I suppose I just wanted to ask if I can get a bit of time with you after this, because I think we're in a really good point now of developing the new partnership arrangements, and the delivery groups are being embedded, and we're looking at developing principles and ways of working for those new delivery groups and the existing ones. And it'd just be good to just pick your brains about how to make sure this is embedded so it isn't a tick box exercise in all, across all the boards. So just put that ask out there.
Thank you. Thanks. That's fantastic, Catherine. Thank you.
I'll be very quick. I think it just builds on what we've said. We've got some new partnership arrangements, as you know. It's really important we have one place where all this is brought in. So I think it's been brilliant progress. What I would say is, again, this feels quite health focused, but actually how many people with a learning disability autism have meaningful employment? You know, what are the other aspects around this that we can do? I think, you know, my ambition is for us to do whatever we can for this population group, because they, you know, looking at the health stats, you know, we do need to keep a focus on it. It does need to be a high priority, not a tick box exercise. So I think, you know, the work that David was describing is great, but it's how we pull it all together, and you know, and how we do that, not just about the health, but actually about a person living, you know, with a learning disability autism. How do we encourage and support them to live as normal life as possible? So brilliant work, but as I say, I don't know quite how we do it, but we've got to think not rhetoric, but actually delivery.
Thank you. And I guess the strategies that Alexis mentioned is probably the way to bring in that wider focus beyond the learning from deaths focus that we've had today. Thank you.
Judy.
Yeah, a really interesting report, Heather. Thank you. Healthwatch has just done a piece of work using art, really, with some profoundly disabled people for them to have a voice. And I think it's I think Alexis probably has seen it's a really inspiring piece of work. And you said about how do we hear from people. I just wonder whether that presentation will be something we might hear in this board, because I think it brings what you're saying to life in a really important way.
Thank you, that sounds great.
Thank you. So could we put the recommendation, like the suggestions on those? Are we happy to take those on board and work on them and find a way to make it happen rather than just have it written somewhere and work together as a partnership, and not as an afterthought, but as something that we think about proactively? Thank you.
Thank you.
I'm going to call for a short comfort break as we are about 20 minutes late on the planned one, and then we come back. But can it be very short? Welcome back. Thank you. And we're going straight into item 10, which is commercial determinants of health.
In the interest of time, I'll hand straight over to Amanda, who I think will do the talking.
Thank you very much. My name is Amanda Pickard, Acting Public Health Principal, Sheffield City Council.
And I'm Magdalena Boo, Health Improvement Principal, Sheffield City Council.
So we're going right upstream for this item, and we're going to be talking about commercial determinants of health. So first of all, just to explain what that actually means, because unless you've heard it before or really think about it, it's not always clear. So by commercial determinants of health, or CDOH, what we're referring to is the influence of commercial organisations and corporate companies on people's health, and that's both positively and negatively. But for the purposes of this presentation, we're going to be focusing on the negative aspects of that. So, I'll use the term UCI throughout this presentation, and what I mean by that is unhealthy commodity industry. So it's that negative aspect of commercial determinants of health. And just to be clear, this is not about being anti-corporate, it's not about being anti-industry, and by association being anti-business. It's very much around being anti-harm and the scale of harm that comes from the commodities and the tactics that are used by these corporates in sort of pushing their unhealthy commodities. So communicable disease used to be the leading cause of death and ill health. So, you know, that's your influenzas and your cholera and basically pathogens, viruses, and all the bacteria that we were exposed to. And as these have come down over the years, we've had a corresponding rise in non-communicable diseases. So in Sheffield, we have around 1,000 plus strokes per annum. And these are largely preventable. And the impact of this is vast on the individual, but also the ripple effect of that on wider families and people who have to care for those individuals. But also, more broadly, the vast impact of those on Sheffield more broadly. So that's our local economy. It's about sickness absence. It's about productivity. And then moving on to sort of health and social care costs, which in the case of stroke are eye-wateringly large. Child health is particularly worrying. So we see, for example, with just taking childhood obesity rates, we've got almost 40% in some of our most deprived areas of Sheffield in terms of child obesity, and that leads to then those non-communicable diseases, cancers, type 2 diabetes, stroke, circulatory disease, often at a young age. So, for example, with type 2 diabetes alone, we've had an increase of around 50% in the last 5 years, and this is our very, very near local, very, very near future local workforce. So the rise in those non-communicable diseases from these products is a big deal. So, and on top of this, they're not experienced equally. So you'll be familiar with the pattern that you see on this map. So this particular one is smoking-related mortality from tobacco-related mortality. And you can put whatever sort of non-communicable disease you like in there, whether it's diabetes or stroke cancers, you'll get a very, very similar image. So it's our most deprived communities who suffer disproportionately from these non-communicable diseases. So why don't people just make healthier choices? So firstly, it's good to understand the determinants of our health. Many of you will be very familiar with this famous image, and it describes the sort of layers of how things impact on our health. So at the centre, you've got age, sex, genetics, things that we can't really change. And as you go out on that rainbow, you've got sort of different layers that impact on our health outcomes. So you've got social and community networks and our immediate sort of community setup. Then we've got education, work, sanitation and employment, housing, and how that then impacts on our health. Housing, particular sort of topic du jour at the minute with the mould situation. And then going out again, you've got the global impact on health. So that's your socioeconomic, cultural environment, environmental issues. So cost of living, for example, is one of the things that's really impacting at the moment. But it's also global as well. So not just that national, it's also the global situation. And conventionally, we focus on that centre. So we focus on age. We focus on the individual to make the changes. And conventionally, we forget about those layers that are impacting on health. More recently, we do start to talk very much more around wider determinants of health, social determinants of health, and what we want to really make sure is factored into that are those commercial determinants of health, because they have a huge impact on how on people's health. So this is what we usually hear when we talk about non-communicable diseases. It's about, well, we need to educate people more. We need to give people more leaflets. We need to, it's around willpower, or it's about lifestyle choices. Well, in the last 100 years, our genetics have not changed. Our willpower has not changed. What has changed is the environment and the space in which we live, particularly from a very commercial point of view. Since '97, we've had 700 different policies on obesity in England, and most of those are focused on individuals having to make those changes for themselves, and all of those policies have pretty much failed to have an impact, and that's because they fail to address that environmental, commercial, and the context in which we live. Choices aren't made in a vacuum; they are made in response to the space, place, and the commercial and the cultural context in which we live. So just a few examples, and I'll rattle through these because I know we're short on time. So McDonald's in 2019 spent over 90 million on advertising in the UK, and that's and additionally to that, around 10 million was spent on advertising of gambling products. The University of Sheffield medical students did a really good piece of work recently where they looked at exposure to gambling adverts in Sheffield as you travel from around the Encliffe area, bearing in mind students are a prime sort of market for gambling products. As you walk from Encliffe into town, they were exposed to 1.03 gambling adverts per minute. So that's over 40 individual adverts that they were exposed to just on a walk into the centre of town to the station. Sheffield ranks in the top 20% for takeaway saturation in the UK. And on top of that, KPMG did a report that revealed that Sheffield was also, as a result, the biggest spender on hot food takeaways outside of London. And on top of that, I mean, and you'll all experience it in your daily lives, you see price promotions when you go into the supermarkets, and evidence shows that tends to lead us to buy around 20% more than we usually actually would when those price promotions are available. Just on the price promotions, they're generally focused around alcohol and junk foods or high-fat, sugar, salt products. And if you live in a deprived area, this is amplified. So if you are poor in society, you have less agency. So, for example, to meet healthy eating guidelines, those on the lowest incomes would have to spend 75% of their income in order to meet those guidelines. 75% and this was prior to the cost of living situation as well. If you live in a deprived area, you're more likely to be exposed to alcohol, junk food, gambling advertisements, both outdoors and online as well. And so when we talk about regulation and trying to sort of change this, nanny state is one of the arguments that always comes up, and actually isn't it all about personal choice? Well, yes, that's one argument that you could try and make, but actually if you regulate, what you're doing is giving people more choice because you're freeing people up from those commercial, those psychologically driven sort of behavioural pressures that we experience in our everyday life. So actually by regulating against some of these commercial pressures, you're actually giving people more choice, more free choice to be able to make informed choices. On top of that, so we know that advertising and availability then leads to people's increased consumption of these products and services. And on top of that, you've got something known as the industry playbook. So this is very well known. I won't go through this in too much detail, but it's very, very well known. It's very evidenced by and it came to light through the tobacco industry and the long history of litigation that the tobacco industry went through. And what's happened is these tactics that have been used by the tobacco industry have been exported and refined and shared between all the breadth of sort of the unhealthy commodity industry. So this is a quote that's quite powerful that was taken from an executive meeting of the Brown and Williamson Tobacco Company. And this is an example of number one, sort of spreading doubt. So this was a quote from them saying, "Doubt is our product since it is the best means of competing with the body of fact that exists in the mind of the public." So what they're referring to there, in other words, is we need to create uncertainty around the evidence that has been developed around the evidence that's coming to light around the impact of tobacco on people's health. So if you can keep that doubt going, you can keep the debate going, and then that is something that's then used to argue against regulation. And a really good example of how we're seeing that at the moment is with the 2005 review of the Gambling Act. So there's been a huge amount of lobbying, there's been a huge amount of funding given to lawmakers, and as a result, the gambling industry have managed to get a seat at the table. There's weekly meetings that have been evidenced between government and the gambling industry. And as a result, there's the Gambling Act has been the review of the Gambling Act has been delayed now 4 times, and that's just another example. I won't go through the others, but it's basically around undermining evidence by placing red herring evidence that is then perpetuated and trying to gain a seat at the table through funding and partnerships. But ultimately, one of the main aims is to try and shift the responsibility from the corporate to the individual. So it's not about our product that's the problem. It's the problem gamblers. It's the problem drinkers. It's people who abuse these products, and constantly trying to shift it away from regulation and towards the individual to make the changes all the time. And we experienced this recently in Sheffield when an outdoor advertising lobby group sort of got wind that we were looking at potentially doing an advertising policy, and I know Greg and myself had literature sent to us by these lobby groups, sort of suggesting that basically we don't do enough education, and it's all the evidence suggests that it's around education in schools and parents, and we know very well that the evidence base does not point towards that, and it does point towards actually what we need to do is change our environment. These are examples of something called social aspects and PR organisations. You'll be familiar with these two particularly, I'm sure. So Drink Aware and Gamble Aware. Both of these are industry funded. They do a very good job of hiding that through layers of funding transfer. But when you actually, there's been quite a lot of research looking at the materials that these sort of organisations perpetuate, and again the subtle messages are always away from the individual, away from the from regulation, so things like minimum unit pricing, and always back towards the individual, and subtle messages against quite often are health messaging. So for example, using phrases like excessive drinking can be harmful in pregnancy, as opposed to our chief medical officer message, which is quite clearly don't drink alcohol when you're pregnant. You know, it's always that sort of like very subtle messaging. And just as a brief example, this is an example from Drink Aware's impact of alcohol on the body. And just the thing to note is that they've used a male body, so that means they don't have to address alcohol and the effects in pregnancy. They also don't have to address breast cancer as well, purely because they've used a male body in the education materials. We're also aware that the alcohol industry is trying to grow the female market. And on top of that, again, you'll see this all the time, signalling virtue, promoting harm. So this is around unhealthy commodity industries trying to seek sort of advance their strategic objectives through collaboration, partnerships, donations through government ministries, hospitals, health agencies, trying to sort of associate themselves with virtue whilst actually promoting harm. So example of Carlsberg and WWF, tastes great, does good, and then Royal Free London Hospitals and Krispy Kreme donating to workers through the pandemic. And here's just another couple of examples. So Coke sponsoring COP27, McDonald's sponsoring kids sports, I've forgotten the word. Thank you, grassroots. And then Shell partnering with British Cycling. And we could talk about examples all day, but that's just a few. So it feels overwhelming, and we often feel quite powerless against sort of when you consider the size of some of these corporations. They out-resource us and they outmaneuver us at every stage. But there are actions that are impactful that we can take locally. So, for example, Transport for London implemented a junk food ban in 2019. And the outcomes for that were evaluated by the London School of Hygiene and University of Sheffield. And they showed that there was a reduction in purchases from energy, reduction in purchases of energy from sugar and confectionery as a result. And then University of Sheffield applied some modelling estimates, and they showed a 4.8% decrease in obesity, 3,000 fewer cases of diabetes were possible, and an NHS potential saving of around 218 million for that area. So, and that's over the lifetime of the population. So these approaches can be highly impactful, highly cost effective, and especially when you compare that to the downstream services that we fund. So when I say downstream services, I mean things like, sort of weight management services that cost us a huge amount of money. So when you weigh up the two, it's sort of a bit of a no-brainer, really. Our recommendations would be that we develop, we bring this to the fore, we really highlight the role of commercial determinants on people's health, and that we develop a commercial determinants of health or an unhealthy commodity approach or strategy, that we develop our own sort of playbook to counter that industry playbook. So we really dig around to think about what are our tools where we can start to impact on some of these influences, and that we use our existing powers as a local authority to try and address the negative impact of UCIs on local residents, and that we start to try and really protect our local residents, and that's particularly our role within local authority is ultimately to protect our residents and give people more free choice. So specifically, some of the things that we're proposing we do are have an advertising and sponsorship policy, that we have a conflict of interest policy, particularly in relation to educational materials for the reasons that we've just outlined, that we have a cumulative impact policy approach for alcohol, and that we use our planning powers to try and really restrict the density and proliferation of junk foods, tobacco, alcohol and gambling. And that we advocate caps and limits on exposure, and particularly in sensitive locations like schools, like hospitals, and around addiction services as well. So ultimately what we're trying to do is just bring the focus from the downstream, and I think Greg mentioned this earlier on in relation to oral health. There's only so much we can invest in treatment services, so we need to shift our focus back upstream and look at, well, who's actually throwing people in the river in the first place, as opposed to constantly looking downstream and trying to pull people out the river at the other end. And finally, there's generally really strong public support for these sort of measures. So Transport for London, when they consulted, they had around 92% support for their junk food ban. RSPH report overwhelming public support for gambling regulation, and when speaking to tobacco retailers, newsagents and convenience stores, around 54% support raising the age of sale from 18 to 21 years. So this stuff is generally really positively received, and I know we're short on time, but I really would like to show you this last video, if it'll work. It's only 40 seconds long, and this was received by Councillor Terry Fox and Greg. Oh no.
Sorry, I don't know how to do volume.
You can read the I think we have to. Yeah.
Yeah, sorry.
It doesn't look like it's going to work.
Yeah.
Would you be able to send it to us?
We will, yeah. So, so just to explain, that was a video that was not prompted. It has nothing to do with us. That came from Bite Back. That was a campaign group of young people who were basically pointing out that when you go into Ponds Forge, what are you surrounded by? So it's very, very difficult for them to eat healthily when their environment encourages them in the other direction. So that's it. The questions for the board, which I should have put on the on the end, are basically: does the board agree that Sheffield should develop a commercial determinants of health and unhealthy commodity approach to framing our local policy and strategy? And how much exposure to harmful, unhealthy commodities is acceptable? How much is too much? And should we have a conflict of interest policy in relation to unhealthy commodities, particularly when it's directly funded around education, prevention, treatment, such as, for example, gamble aware and drink aware. So yes, it was. Hopefully the questions were in the report.
Thank you. Thanks, Amanda, for that. I'm very conscious of time. We're running really late. Are there any pressing questions? Are people happy with the... Oh, Greg.
Just not a question, comment, but ultimately much of this is about multinational corporations. This isn't about the local economy, it's about multinational corporations. And there's a lot of recommendations. I'd recommend the board agree them. The only question is how hard the board wants us, my team, but also the local authority, to push in this space. It's always pitched as a David versus Goliath battle. David won in the end, and I'll remind everybody of that. This is about being skillful to change the choice environment and not harp on individuals to make responsible decisions, etc.
Do you want the chair view on this? Do you want the chair? Well, the chair view is that we go as hard as we can, because if we are promoting well-being and health, you know, we cannot back corporations that are harming people ultimately. How do people feel about it? And how do we do it with the partners, though, as members of this board?
Sorry. Absolutely. I think we should. I quite like the David Goliath battle type thing, and part of it's being smart and thinking of ways around it and being innovative. And we talked years ago about how we could use the brands, the NHS brand in particular. You know, could you encourage businesses to actually behave differently and maybe say that, you know, we'll then actually let you use our brand, you're working in partnership with us. So I think there's a lot of innovative ideas out there. I would go as hard as we possibly can. I think we've got to do something.
I would very much like to support this for 2 or 3 reasons. Number one, I think we need to go very hard and fast. I think number two, we need to look at what's the economic impact and actually as a result of this, because when I look at it from a social care perspective, is actually what then happens is actually in the longer term, what will happen is people will need longer term care, and that is ultimately will be one of the financial impacts of exactly that. So I think what we need to do is actually put a cost value to this, for want of a better word. And then I think what we then do is think about exactly the playbook, and we start to think about how do we start to work around this, because I've always been a fan of upstream preventions, because I would rather prevent rather than do. And I think I would very much like to get involved in this and support this piece of work, because I do think if we could do anything really around the prevention element to this, this is exactly it.
Amanda. I'll take Judy and then we'll close it if that is okay.
Agree with all that. I think we should go hard. I think with a really sharp communication strategy as well. We've got to tell the story well.
We're going hard on it, Greg. Thank you. Okay, we're moving on to 11. It's a verbal update from Emma, I assume.
Yeah, I'll keep it short, Chair, if that's okay. I'll probably bring something back a bit more formal because I'm conscious of time.
Great.
So for those of you who don't know me, I'm Emma Latimer. I'm the Executive Place Director for Sheffield, and I'm part of the Integrated Care Board. And I note on the agenda the Clinical Commissioning Group is still referenced, and we were actually abolished at the end of June. 2022 and replaced by the South Yorkshire Integrated Care Board, of which there are 4 places, Sheffield being this one, and I am the Executive Director who has responsibility from the Integrated Care Board into the place partnership arrangements. So in terms of what the place partnership is, it is obviously a collection of all providers, what we'd call the ex-commissioners, which is the Integrated Care Board, local authority who does both, the voluntary sector, Healthwatch, and we're coming together really to talk about what we can do around collaboration for health and care. It is very much what it says on the tin. I think we've got 3 key jobs. One is about integration, so leading the place partnership to develop integrated models of care at the point of delivery, to deliver measurable improvements in health and care. The second is to involve, to ensure that the voice of local communities is heard in developing place plans, and that there's authentic and demonstrable involvement of local people in that. And the third, I guess, is just to kind of inspire. So inspire by working together differently, thinking about people rather than services, and doing things once. So I think Sir Nigel Crisp, who was a previous chief exec of the NHS, has written a book, I don't know if you've read it, which is Health is Made at Home, Hospital is for Repairs. I would ask you to look at that, because this is very much the principle and where we're working. So actually we can't just consider health alone, we have to think about the wider determinants and the impact of what we do. And so the purpose of that partnership board is really to deal with the very difficult things we're facing now, the business as usual stuff, all the targets that we have to deliver that are still there. There are still some major issues around workforce and finance, and we need to ensure we're doing that, but also that we take a longer term look at what we're doing with our health resource and our care resource, and how we can start to change things for people and do things differently. So we've still got great clinical leadership and involvement. I'm sat between 2. And their input is really important, as is Greg's as the Director of Public Health in that space, Alexis and lots of other people, and yourselves as elected members. So again, the good thing I think about integrated care systems is that we don't just look up to NHS England, we also look horizontally to our elected members who have democratic legitimacy for the place of Sheffield, and the voluntary sector, and all of our communities that work with us. So basically, in a nutshell, we are trying to do things really differently this time, to really reflect that long-term ambition to improve the health and well-being of the people we serve. So I know that was quite short, and I'll bring something back that's at a future meeting, unless anyone's got any particular questions given the time constraints that we face.
I don't think so, and thank you. And it's really good. I know it's only a short space of time that we've been working together. In fact, that the ICB is being placed by. It feels to me that it's moving at pace. It will take a bit of time to embed, but as long as we work together, I think we can potentially deliver something completely different.
Fingers crossed. Thank you, and thanks
Brilliant.
for your support.
Thank you. We're moving on to the next item, which is the primary and community mental health transformation.
Whilst Fiona and team get set up, so 3 thoughts. One, historically, I think this board's underplayed mental health. So here's an effort to begin to put that right. Of note, there's a themed meeting on mental health being planned for sometime next year, timing to be confirmed. This is an update about a specific piece of work that's been underway for quite some time. Nikki might tell us how long, but a recent University of Sheffield evaluation. So Damien, who led the evaluation, and Nikki and Fiona, who did some of the hard work, but I suspect others also did. Over to you.
Thank you very much. I think I know most of you, but for those of you who don't know me, I'm Nikki Doherty. I'm Deputy Chief Executive at Primary Care Sheffield and Director for Business Development, Partnerships and Strategy. So I'm just going to introduce it. Damien's going to do most of the work, and Fiona and I are going to set a tiny bit of context, and quite helpfully following on from you, Emma, because a lot of what you were saying is exactly what we've been doing. This has been going since 2020. The work to get there was before that, but we went live in COVID as a innovation service. So what we've achieved is quite staggering when you hear about it all. This is something that we've done to support people with serious mental illness. We've done it in a very innovative way, working into PCNs. And those of you who hear me talk about primary care at the moment, you'll hear me say quite frequently there are 3 really important reports for primary care. The fuller stock take, the Nat Jones report, which is about how ours roles work together, the additional roles that are going on there, and then this evaluation report. And the reason for that is because we're learning how to work differently in primary care. Primary care set up on lots of individual practices that are individual organisations and companies in their own right that are built around patient list sides and a certain funding model. So this is probably the first test of primary care networks to really, really work differently around a population rather than their own practice. And we've done some staggeringly brilliant stuff in that space, but we've also learned a lot about the support and the organisational development aspects that need to come as we move forward. We've done this in partnership as a city, so Sheffield CCG at the time and now the ICB, the Sheffield Health and Social Care Trust, the local authority, Primary Care Sheffield, the ICS and, importantly, Sheffield Mind. And some of the accolades that we've had nationally are in recognition of that partnership approach and just how important that has been. We have, as one of the 12 early implementer sites, been recognised for exemplar working. We continue to be doing so in terms of the innovations that we have around how we're going to make the partnerships work. Equally, we are multiple HSJ award winners, which is quite staggering when you go back to, we set this up in COVID and we really did put something in place that was flexible and responsive to people. So we hadn't tested it out, we haven't done it before. It's important that we've done it differently. And I think what I'm really hoping that you get from this is a real flavour for how do we apply what we've learned here to more. Fiona.
So thanks very much. Just for those of you that don't know me, I'm Fiona Gowdy, Clinical Director for Strategic Partnerships within Sheffield Health and Social Care Trust. I think a couple of points from me before handing over to Damien. So this initiative around primary community mental health transformation, for which we're one of the 12 early implementer sites, is probably the biggest mental health shift in the last 30 years. So I think it's important to acknowledge that. So this way of delivering services in a wraparound way, focused on primary care networks in partnership across horizontal partnership, actually, to pick up on I think Emma's point earlier, across the voluntary sector, primary care and secondary care with citizens and communities is innovative. So what Damien's going to be reporting on is the work that we did with 4 of the primary care networks, neighbourhoods, and those were chosen to support. We chose those areas with the highest IND index of multiple deprivation in the city, so that covered about a third of the population. And there's some information that is on the slide and that we've already circulated about the teams. But just to talk about the governance arrangement, which is through a joint executive board between Primary Care Sheffield, Sheffield Health and Social Care, and Sheffield Mind on behalf of the voluntary sector, and I think that's something that's been quite innovative. And fits very much with what Nikki's already, I think, mentioned in terms of lots to learn from that approach beyond mental health. So, over to Damien to give you the key outcome information.
Yes, thanks. So we, a team at the University of Sheffield, were commissioned to do an independent evaluation of the of what was effectively a pilot across certain areas of Sheffield. We looked at the data that the service was collecting in terms of the number of people seen and the background of people seen, but we also looked a lot at the process. It was a process evaluation to see what was done well, what was done badly, what we can learn from that process in terms of taking this forward. Between, I guess it was March 2021 and summer last year, the evaluation was conducted. You can see from I think the text is quite small, but you can see from there that there was a significant number of contacts. This really reflected what we saw as a lot of, I guess, a backlog of pressure upon the system overall. What was striking about the usage of the service, and I think this was reflected where this has been done in different ways elsewhere,
is that it largely was, the uptake was largely among people of working age. It was predominantly used by female rather than male service users, and it had a significantly large number of people from black and minority ethnic communities who engaged with the service. So this was quite striking compared to the normal delivery of mental health services. So we have written a report. I've actually got a short version of the report. The report's about 70, 80 pages. Can I pass these around? Okay. So we did a short four-page briefing. Both these reports are available online, and the links are there. Obviously, in the time we have now, I won't be able to go through all of the detail, but hopefully you can see from the table of contents there, what we did was we largely looked at the... Move on to the next slide. Yeah. This is a kind of standard format for an evaluation. We looked at the context in which this took place. We looked at what it achieved, what were the barriers and challenges faced, which things enabled different aspects of the service to deliver, and also what elements would be important to reflect upon in terms of rollout and sustainability. Of course, I won't go through all of these, but I will pick up on some of these which possibly have the broadest relevance here. I've mentioned system pressure. In this, we mean not simply the pressure on mental health services, but across the whole health and care system. So given that, and the fact that this was rolled out during COVID, this had a significant effect. There was a lot of demand, but also significant levels of complexity. I think it came out very strongly from the service users and the staff we interviewed that many people were struck by just how complex the cases were that were being dealt with in the community. In terms of the achievements, I can certainly talk about there was very strong sense from staff and also from the service users we spoke to that there was good care being delivered. Better care than they'd often experienced in other mental health services that they'd had experience of in the past. I think the things I'd probably pick out here is that what was striking was that the service was able to understand unmet need at a local level. So a lot of this was based upon PCNs, upon neighbourhoods. So a great deal of the work was about saying, what does this neighbourhood need? Not about what is across Sheffield or across the region, but what is the particular need which reflected demographics, which reflected population, which reflected all kinds of economic and social conditions in each particular area. And that meant that the teams evolved with different particular skills and different compositions of capabilities. They work closely with GPs and with the primary care setting. I think moving on to the barriers and challenges, this was a pilot. This was started, I say, in difficult circumstances. I think the novelty presented certain challenges, the understanding of it across the system. It's a complex system already, and therefore bringing a new service, it is quite hard, and it was very hard during COVID to try and communicate what the system was and how it was different. What this led to in an ongoing way were certain coordination challenges. How does this link in with other services? How does this link in with the trust, mental health trust in general? How does this link in with social care? So this was an ongoing process of learning how to relate to different, and learning the differences between how these different organisations and systems worked. In terms of the enablers, I think what came through very strongly was two particular things, the first 2 points there. That one of the things that drove this forward was a strong belief among the staff that this was the right way to do things, that this was a better way of doing things than had been used in the past, being focused upon localities, focused upon local need, and having a particular commitment of flexibility to say, rather than how do you fit in with our system, how do we make our system fit around your needs? And that came through very strongly in terms of both the therapeutic methods that we used, but also how they approached service users and how they engaged service users. And then I guess the final point I'll probably make about the rollout and sustainability, this took place over 4 PCNs. While we were doing the evaluation, it was rolled out to 2 more, and then the idea was to expand beyond that. So within that process, the question was always about how do we get the right structure at scale? What's the right, if you like, dosage that we need to have across the population, and how to make this financially sustainable, and also something that the staff themselves can cope with in terms of demand. So, again, very briefly, if I'm trying to summarise the report in 4 or 5 bullet points, or 7 bullet points, it was clearly successful in reaching marginalised groups. It was clearly successful in tailoring care to local need, and it went much further than not just previous experience in the city, but I guess many of the other pilots I've been involved with elsewhere in across England struggled to engage with general practice, and this was not a problem here. This was co-led, and general practice had a strong voice in this, which made a huge difference. The scale of demand and the complexity of demand was a problem and continues to be a challenge, I think. Or certainly by the end of the evaluation, this was still something which was being worked on to make the demand manageable for the staff who were doing this. There were ongoing challenges. How do we link this with IAPT? How do we link this with the other services that we have in the city? What came out strongly was that the voluntary sector had a very strong role to play, and that was being developed throughout this. And community assets also made a major difference. I've mentioned flexibility, innovation. The danger is when you scale these processes up from a pilot, often things get standardized and you lose the flexibility. So one thing we've said in the report is very important to think of how to maintain flexibility and how to ensure that innovation is learned from and spread across the system. And finally, the question of scale, about how do we do this at the appropriate scale, and what is the right level of provision, given that each neighbourhood has different needs and different degrees of need as well. So in the report there is a significant number of recommendations organised as we could by theme and by stakeholder. I will pick out 2 or 3 just that strike me now. One is to do this well, would rely upon a joined-up estate strategy. One of the challenges with estates across different areas, what's the provision of actual accommodation for the activities. But one of the things that was learned is how we could use community assets in order to deliver the service outside of primary care premises. There's a need to actually bring in data from other services to understand need, not just from primary care or from secondary care, but also from across social care and other areas. And that would help inform what's the provision, but would also help to evidence impact of this. And finally, what would really help would be some kind of joined-up development activities between different parts of the system, so that primary care understood better how social care works, so that the voluntary sector understood better how primary care works. And that would, again, it goes back to the issue about linking up across the different systems. It would make a huge difference. So I think that's all I'm going to say for now. So I guess it's questions.
Greg?
Thanks, Damien. I had read the report before because it came to the launch. Thank you. Only question. So there's 47 recommendations, which is good going even by my standards. What's the sort of the machine to consider, implement, keep moving that one on positively? And does that machine exist? I might not know about it.
There's 2 mechanisms we've got, because we've got kind of business as usual through the 6 now PCNs that we're running. So there's a joint executive board between Sheffield Health and Social Care, PCS and Sheffield Mind. So with the operational stuff and where we need to improve there, we're overseeing some of those actions. And then the other bit is into the transformation board. And actually one of the reasons that we're coming here today is because some of those recommendations go beyond the scope, as Fiona says, of mental health, and therefore we want to make sure that we're embedding learning and the way in which we do this together. One of the reasons primary care engagement, general practice engagement was so successful, just one of them, there's many reasons, is we've got a very unique partnership approach in Sheffield. So no one else has done the kind of federation acute trust collaboration. The acute trusts have tried to engage in primary care and they haven't got the relationships or experience to do that well. We got special dispensation to do it in Sheffield, but the benefits of that have paid dividends.
Lee and then David.
Thank you for this report, and thank you for the project as well. Yeah, speaking as a GP, I know we've benefited from it and from one of the pilot sites as well. I suppose just some observations, not at all surprised by the complexity. that people were surprised by. That is being managed continually in primary care, and it was quite helpful actually and affirming to see it in black and white, it being recognised, the level of complexity, not particularly for practitioners, but for people living with that degree of complex mental health and enduring mental health and trying to navigate through life with that. So it was really actually quite helpful to have that documented. I think there was a challenge, particularly early on. We saw that referrals went down, I think, and that was partly because the service was overloaded. You know, it was a victim of its own success, and referrals had to stop. And that again feeds into this issue of mental health resourcing is under-resourced. The issue of paritative esteem, as we know, is still very complex, and we do, as a city and a system, we really, really need to think about this, because there is no health without mental health, and it has a huge impact on all the physical stuff and acute stuff that we seem to spend a lot of money in. So we need to really, really think about that in this space. But I suppose the observation and the beauty of this programme was that it's locally sited. And that's what enabled really good relationships to happen between all the practitioners and people involved in it. It's what made it accessible, not just geographically, but culturally accessible. It was a familiar space, and if you're working in areas with socio-economic deprivation, we know there's loads of evidence that siting services locally is what makes them accessible. So that's a really sort of key thing to learn from that. The other thing about it being local and people being relationships developing between all the different partners within the project is that's what enables flexibility, because it can feel quite scary for practitioners to step out of their very rigid guidance of, oh, this is this condition and needs to be managed this way, and to go, oh, actually this is this person and this is what's needed here. And it can take people into quite scary places professionally, and that's mitigated by having it being a team effort and a team approach, and that only happens because it's working locally. So I think as a sort of learning point, and thinking about how we roll it out, and understanding that when you make it bigger sometimes you lose that flexibility, is keeping it sited local. And the thing that then does is it empowers practitioners to be more innovative, and I think that was a really, really important part of this. Thank you.
Thank you. I have David and then Alexis.
So, apologies, I'm David Black, Medical Director at Sheffield Teaching Hospitals. I can't, maybe it's there, but I haven't spotted it. But what was I don't really know what the people had wrong with them. What was their diagnosis, and did they actually get better? Because I can't see any mental health outcomes. Did their mental health improve?
So, I'll answer the first bit of that, and then Damien can maybe answer the second bit. So, the entire cohort that we were focused on were those people with serious mental illness. So these are people that were in the gap between what IAPT supports. So these were not people with mild to moderate anxiety or depression. That's what IAPT was designed for. Nor were these people who needed to be admitted to psychiatric beds. There were people with serious mental illness, psychosis, stable schizophrenia, if you want, diagnostic terms, personality disorder, above the age of 18. So these were adults. But as we've been discussing, there are often significant comorbidities, physical health problems, economic challenges, wider determinants, housing, and so on. So that's the population. And in terms of the outcomes, I'm going to ask Damien to say something about this, because this was the start of a pilot.
Yeah. The two things I say is, first of all, it was commissioned as a process evaluation, not an outcome evaluation. I would also add to that, I guess, really, that this was done within 12 months. So it was 12 months from the start of the service. So the likelihood of seeing effects upon someone's health at a scale that you would be able to measure and attribute to the programme within 12 months is pretty unlikely. So what we said at the time is what we would work on this is identifying what would be meaningful data to actually measure impacts of this, and through this time the data that's been collected has been changed, the format has been changed and so on, but we'd like to do a follow-up piece of work, because we can see that there's probably strong evidence of that in there, but we'd like to be able to back that up with some further study, really. So yeah, it would be the next piece of work, and I think we've started discussions about how we might do that right now.
I mean, qualitatively, there's a video that some people will have seen, the service users that we interviewed, I think qualitatively, were very, very positive, but obviously from a kind of numbers point of view, that is further work to be done. And as you're probably well aware, mental health outcomes are not anywhere near as well developed as, for example, in relation to some of the acute pathways like stroke, for example, which are kind of the gold standard in terms of outcomes. So more work is needed.
We're going to be leaders on that one though too. And I suppose the other bit, it goes back to Lee's comment, is there's a risk that we're carrying at the moment because we haven't completed that organisational development. So the coming together of cultures, and it's actually very difficult to get primary care to remember this isn't a secondary care service that we're referring into. It's really difficult to get secondary care to remember it's not either a community service or a secondary care service that we're running in. So we're constantly managing that, and we cannot be in a position where we have another set of weights. We need to make sure that we're managing it as a community, if you go into some of the networks, they will talk about it not being the mental health team, but it's hundreds of people working across all of the practices and community organisations to support this group of patients, and that's the bit that we need to do to make sure we do get the outcomes we know we should be achieving.
Thank you. Alexis.
Oh, sorry, forgot. First of all, just want to say a really good piece of work and a great foundations for the future. And do you know, it's been lovely to see the journey of this. I think the learning from the journey, because I always think it's not so much just about the what as the how that has been just as important. I think that and along this, and I think we need to thank you for all the work that's went into this. And I think for me, secondly, is what we've talked about is actually how we're building some of the future design of social care and build upon some of the learning around us. And one of the key things for me is about that connectivity and taking some of the learning here and how we start to go forward, particularly in that neighbourhood and that community kind of reason going forward. And I think the third thing for me is thinking about how we take all the learning from this and we take it into neighbourhoods and we take that as the next stage, because I think that what we've seen with a cohort of individuals is actually could improve outcomes by just working in a very different way at a very practical kind of operational level and breaking down some of the organisational barriers that sometimes get in the way of doing that. And for me, you know, when I come back to the social care future design and how we've been linking into yourselves, I think, and equally the neighbourhood design, that's what we need to kind of think about, perhaps as the next stage, and start to expand the learning as we go forward. So again, I just want to come back and say a huge thank you. And one of the things that Zach we're talking about earlier on is how we bring back to the Health and Wellbeing Board is actually perhaps that wider piece of work as a collaborative together. So I'm going to maybe take that as a bit of a job card and I'll put that and take that forward.
Thank you. I have Sharon and then Emma.
Thanks. I mean, I've only been chair of SHSC for a year, but it has been a resoundingly positive partnership as far as SHSC are concerned. And I think they've worked really, really well together and hopefully should have really good outcomes. I think it's also worth saying this is influencing other transformation going on at SHSC and linking with it. So we're transforming our other community services and other services, and the learning from this and the link with this to make it as seamless as possible is also helping us with our other transformation. So I think it's having a positive impact even beyond the scope of this work in the organisation and for the people who use the services. So thank you all.
Yeah, just to echo that, it's a great piece of work and really does fit into the integrated care space. So I'd like to say brilliant, and when we're going to roll it into the other PCNs.
Our timeline for that, so I think originally we'd said March, but then there was a bit of a hiatus with changing leadership and various different things. So we're now looking at October 2023 with a significant number of challenges. This bit was almost, because we were an early implementer, we got additional funding. We could recruit to posts that were new and could do what they want. The next bit, which is where Sharon was speaking, is it involves changing the roles of people and what they do. So there's a huge amount of change management process, which is very exciting. And I have to say, there's a lot of support and enthusiasm. We're not kind of pushing against closed doors, but it is going to be a challenge.
Well, any support you need through the partnership, let me know, because I think, you know, we need, if it's working, it's proven it's working, then we need to think about scalability of these things to make sure they stick. And I think David's point around the outcomes is really important. But what I found is that there's a huge amount of unmet need in the system that we've never measured and so when people say, you know, can you measure it? You know, and the voluntary sector do so much to prevent demand seeping into statutory services. So I think it's really important we have an eye on that, but also recognise the context in which we live. So thank you.
Am I able to just respond to just quickly? One of the things that would be great, Emma, there is one of our observations is, although we aspire not to have waiting lists, because that's a bad thing, and we have to work in a different way, what the waiting lists are doing for us at the moment is giving us a very good, useful measure of just the scale of that unmet need. So doing a piece of work around what we do with that before and not losing it would be great.
And also it's the non-medical elements as well, you know, in terms of what do we do, how do we wrap support around individuals and families. So yeah, thank you.
Thank you. Yeah, thank you very much. It's great. I read the report, but I want to read it again, like in 2 weeks' time, and just take it because it was very detailed and it's really, really clear. That's what's really good about it. Thank you. We're moving on to the next item. We're still 25 minutes behind time, so it's infant mortality. Not sure who's presenting. Is it Amanda?
Whilst Amanda and maybe Julia get set up, I'll be quick. So this is an ask on the board to endorse the development of the content of the next infant mortality strategy. Over the last 10 years, we've halved the rate and narrowed the gap really, really cheaply. So the job is to continue that and accelerate.
Hi, so no slides this time. I think I've used up my slide quota earlier on. So I introduced myself earlier, and this is my colleague Julia.
Hello there, I'm Julia Thompson, a Health Improvement Principal in Greg's Public Health team, and my area of responsibility is maternity and early years.
So just a disclaimer initially, just for the next 5-10 minutes I'm going to be talking about infant mortality, which includes child death and cot deaths as well. So whilst there's no graphic information, it's just a little disclaimer that some people may find that a distressing topic. So just as a reminder for those who don't know, infant mortality is defined as the death of a child born between 24 weeks gestation and under 1 year. And overall, it's a really positive picture that we have at the moment in Sheffield. So our rates of infant mortality have fallen by around 42% since 2005. And whilst the England rates have done something similar, they stalled around 2014. However, in Sheffield, we continue to fall in our infant mortality rates, and we've exceeded the targets that we set out in what is the current strategy that's now coming to the end of its life. So we see around, our rates are around 3.5 per thousand, and that translates to approximately 21 deaths, infant deaths in Sheffield per year. So we're ranked as 4th out of 16 in our nearest neighbours in terms of local authorities, and like I say, we're below the England average now, and we sit well below the Yorkshire and Humber average. And the inequality gap as well, this is something we don't often see, but the inequality gap in infant mortality is actually closing, which is a really refreshing picture to see. So the current strategy was written in 2014, and it was shared with STH and also the CCG at the time, but it was owned by us in Sheffield City Council. It's made up of 8 themes, so maternal obesity, smoking in pregnancy, early access to maternal care, breastfeeding, child poverty, genetic recessive conditions, and teenage pregnancy. And we've had excellent progress in several of those areas. So I think we talked about breastfeeding earlier on, so our rates are better than both the England and the Yorkshire and Humber average, as are our smoking in pregnancy rates, which have come down hugely in the last few years. And it's a testament to the whole systems approach and the multi-agency approach that we've taken in Sheffield. However, given the current situation and the fact that infant mortality is strongly associated with poverty, given the current situation around cost of living and the energy crisis, there's a real risk to that positive progress that's been made. So we've got families moving into poverty for the first time, and those already in poverty are pushed sort of closer and closer to the edge. And one example of how that plays out is, if you're not able to put your heating on, you're more likely to be tempted to take baby to bed, into your own bed. And then obviously you've got a very risky sleep situation for the baby when you've got adult bedding involved in that situation. And also the financial pressures that then lead to relationship and domestic issues then lead to changes in sleep practices where, one parent and baby might go sleep elsewhere in the house because of domestic problems. And then again, you're introducing that risky sleep practice. So there's a real urgency to refresh this strategy, and we're sort of halfway through that process at the moment. So the refresh so far is to look at those 8 themes that we've got in terms of evidence, but also seek professionals and stakeholders' views around sort of what the current provision is. Look at where we can start to plug gaps or to sort of seek what people's views are on what those gaps might be. Working collaboratively with organisations who gather insight and learning and have service user voices in this space, and looking to run multidisciplinary stakeholder workshops around some of the themes that we know needs a little bit more attention in terms of sort of fleshing out what we might want to do. So, for example, that covers things like maternal obesity and also safer sleep and possibly poverty as well. We are... first of all, it should be noted that the cost of the infant mortality strategy to deliver are minimal in relation to some of our other sort of strategies and work that we carry out. So the only cost to this are around, we have some money that goes into genetic literacy projects, smoking in pregnancy contributions that we make, some staff coordination time, which isn't even a full-time post, and infant feeding as well. So in terms of sort of impact on outcomes versus what we put into this, it's a huge sort of success story so far. So our early recommendations are that we keep the 8 themes, but instead of having sort of poverty separated out, that we have that running throughout all of the themes as a thread. That we highlight the role of wider determinants and also commercial determinants that we talked about earlier on. So that might be in relation to something specific like maternal obesity, and that we also need to acknowledge that whilst the strategy is focused on infant mortality, it also has huge wider positive impacts, and it's not just infant mortality. So we need to be more explicit around the additional outcomes that we get from having this strategy and working on these 8 themes. Some of the conversations that we've been having with settings so far have really highlighted the role of the trusted individual, and that's over sometimes the role of the statutory professional working in this space. And by that, what I mean is, as an example, a parent of a newborn, especially someone who's maybe experiencing sort of true poverty for the first time, given the current situation, because of stigma that's associated around poverty, they might be tempted to withhold information from say a midwife or a health visitor for fear of sort of implications of that. So they might not sort of disclose the full extent of the issues that their family is facing, or they as a single parent facing. So, but who they might disclose that to would be maybe a trusted member from another setting. So say a nursery setting. We've got good examples of where this has happened, where we've got people disclosing really sort of detailed sort of risk factor information to nursery settings, or for example to a volunteer doula who's had that time to develop a real close relationship and a trusted relationship with the family. But also, another recommendation we're looking at making is trying to build awareness and knowledge of the red flags and risk factors around infant mortality amongst not just those working specifically sort of in the space of sort of children and maternity and young people and young children and maternity, but also those having contact more broadly with the family. So it might be trying to upskill sort of housing maintenance staff, for example, who are going into sort of families' home and seeing sort of firsthand the situations, or maybe able to identify some of the red flags around things like safer sleep, for example, that we talked about. that also extends to other partners. So, for example, the police who are going to families' homes to carry out safe and well checks. We'd also like to propose re-establishing safer sleep champions amongst professionals and the community, and that would be using some baby safe branding. And ongoing support can be facilitated through family hubs and people keeping well who already receive funding around early years peer support. We'd also like to build, related to that, build further on the opportunities that are being brought by the Great Start in Life funding and the expansion of the family hub services. We'd also like to review and potentially increase the volunteer doula programme. And that's due to again, the role of the importance of that trusted relationship that's developing, but also the positive outcomes for such a low cost initiative. And the final two, to support the case for continuity of maternal care, again because of that trusted relationship that needs to develop, and the information that you get in those cases of a more familiar, trusted relationship that mums to be or families develop with those individuals. And finally, better data sharing that we're working on to try and help identify vulnerable parents and families. So in conclusion, it's a really good news story. It's a really good value news story as well. So the outcomes we get for very limited amounts of money that we put in, and that we've achieved our targets basically on a shoestring. And again, it's a real testament to that. Multi-agency and whole systems sort of approach that the strategy's taken. So we're not proposing large changes to the current strategy because it's clearly working. We're doing, people are doing something right, which is really great. But there is a real risk to the situation because of the current situation that we're in terms of cost of living. So questions to the board were, how can the board help us raise the awareness of infant mortality risk factors and also the strategy and the actions that we need to do in order to address the current situation. And we ask the board if you can help raise the awareness of the risk to the infant mortality progress in Sheffield due to the cost of living and energy crisis. So really sort of help to sort of bring it to the fore really in terms of importance because of the context. And how can the board help take on some of the actions that we've raised within this paper? And then an additional sneaky one that's not in the paper, I'm afraid, but also whether you can help us identify safer sleep champions within your own organisations and sphere of influence as well. And that was it.
Thank you. Before I bring people in, can I just suggest, as you're working on it, could we embed the Race Equality Commission recommendations in this? And
sorry, I missed that. Sorry.
Could we embed the Race Equality Commission recommendations into this, and how different targets may affect different communities, and also, of course, look at how disabled parents or people with learning disabilities or children with learning disability or physical disability, how they compare. We just had a report earlier on, so it'd be good not to have to add things on, but have it already in, and anything else that we've discussed, really. Thank you, but it's really good.
My brief point is, I know the environment's changed, we've got poverty. The strategy needs to focus on things where you can act and know that will make a difference to child mortality. So the previous 8 are really good. So we need to keep a focus on smoking in pregnancy because you can do something about it. Teenage conceptions, because you commission the services that stop teenagers getting pregnant, and monitoring that as part of the strategy is really important. The breastfeeding is really important as well. And those are really crunchy things that you can do, because I fear we're all going to struggle a very great deal with what to do about poverty and cold houses, because it's much more difficult. So focus on things that we can really do, build on the success of this previous strategy, which has been great. And just to note that the Trust Sheffield Teaching Hospital is working very hard on its maternity services, and I'm confident that our next CQC rating will be better than the one we have at the moment, which I think is great news for reducing and supporting work to reduce maternal mortality, and we're very keen to support you in the work.
Lee and Sharon.
thank you for this. We all love reports, don't we, where actually not much money has been spent and lives have been saved, which is what you're talking about really, you know, lives being saved and the impact that will have. So that's fantastic. I really welcome that emphasis on trusted individuals, trusted relationships, not necessarily lots of quite expensive professionals coming in, and I think that goes across the board in whatever we're looking at, where there's any sort of sense of vulnerability. Really emphasising that role is really important. In terms of what we can do, I'm thinking of my organisation's general practice, primary care networks. It might be worthwhile speaking to primary care networks to see if they can have safe sleep champions. You know, there's a lot of work now going into public education in very different forums. And the only other thing that crossed my mind is it's a very long time since I had my children, but we used to have antenatal classes, and I think they stopped. I don't know if they did or not, so I could be wrong. I think how they happened probably wasn't great anyway, because in my day, it was a midwife offering it in the hospital at night. Do you know? And actually all that we've learned this morning about, you know, locally sited services within culturally appropriate settings in the communities where people live, do you know, that might be worth, in terms of peer support and developing those trusted relationships, that might be worth thinking about as well.
Could I just sort of come in here, because I'm involved at the moment in the development of the Start for Life programme, which is the transformational work for family hubs. And you've touched on something that's a really important area of development as part of that programme. The antenatal support offer is something that we're really focusing on and thinking about how we can work collaboratively with colleagues in maternity services to sort of expand the antenatal sort of parenting educational offer, making sure it's really inclusive, ensuring that dads are part of that as well, but also thinking through the sort of postnatal support that flows on from that work into the community and the kind of services that are going to be enhanced at a local setting through Start for Life. So that all really resonates and ties in well, I think.
Thank you. I have Sharon, then Emma.
Thanks. It is a really good news story, and fantastic, because these are people that, you're right, Lee, these are people's lives, aren't they? You know, and I think we mustn't lose that in the strategies and the words, because this is about people and lives. So I think you're right about, you need to get this out as wide as possible. You need to bring this to attention, and everybody needs to be aware of it. And I suppose in the communities, it might be good if you had some advocates from the community, people who have been involved in this. And I'm sure there are loads, and Helen sat next to me. I'm sure she'll have something to say about it. Mine was just a quick question about SHSC, because I'm the chair of that. And it's just, we do perinatal mental health, and that goes up to a year. So I presume you're closely connected into those services. Yeah, that's great. Thank you.
I have Emma, Greg and Helen.
Thank you. Yeah, a great piece of work, and I love your passion about things like this. It shines through. I think I'm really interested in the Start for Life work. So I think this is kind of the very sort of the very start of life, isn't it? But actually, the whole Sure Start is one of my favourite topics. Is Sure Start. You know, reintroducing Sure Start. And again, I wonder, Greg, whether we could have a bit more discussion around the Start for Life work in the partnership arrangements. You know, because we as the health tend to focus a lot on adults, don't we? And actually, I'd be really interested to see what else we can do to support some of that agenda moving forward. And I know Andrew was, I don't think Andrew was at the meeting last week, was he? But again, I'd be really keen to sort of think about how this connects into some of the work around children, families, the old trouble families as it was. Or now, I know it's called something else now, family hubs, is it? But yeah. So sorry, that was a bit of a garble, but you know what I'm saying, really. I just wondered whether we could have a bit more insight into what was going on with children's services.
Yes, in short, there's a whole bunch going on in that space, and it's fair to say that the frontline NHS staff fingerprints are all over that in all sorts of shapes and guises. There's much we can do to kind of coordinate, connect the story. Two other thoughts. I'm taking it as read that the board are endorsing the broad thrust of where we're going on this one. I don't think anyone's going to argue with that. We will come and tap people on the shoulder at various points to kind of seek proper endorsement for very specific things within it. To picking up with David's points, the 8 programmes are going to remain. I don't think they're going to change, because that's what the evidence tells us to. Therefore, we're going to do that in the way that we have. And we will tie all of that up to the developments around family hubs, because there's a whole bunch of good stuff and new investment actually in that space. So who would have thought? So we will focus on what we have done and do that consistently, because that's how we've achieved what we've done. The grinding consistency of the delivery of evidence-based stuff cheaply and coordinated, that's how we've achieved what we've got. So we will continue.
Thank you. And Helen?
Yeah, just to add the role of the VCS in supporting some of that relational stuff. I think you're aware of it, but I think there's an opportunity to scale up and to grow through the community champions and other roles. Happy to support with that, but I think also just thinking about the role of community organisations and VCS in the areas of sort of challenge around accommodation, and actually when you look at some of the sort of root causes, people knowing the rights and having that sort of confidence and support to challenge, I think is really important. I think there's a conversation we could have about how we sort of grow that and support more capacity around that. And then the role of volunteers, doulas or other types of support. Again, we can think about what we've already got and how we can grow practice that works, and whether there may be new solutions that we can help to develop around volunteering.
Okay. Great, thank you, Keith.
Thank you. So the 4 recommendations for the board are to recognise the good progress on infant mortality since the incept of the last strategy, to acknowledge the risk to infant mortality progress in relation to current cost of living crisis, to raise awareness of infant mortality risk factors and incorporate action to address these in their field of influence, and to endorse the approach to the current infant mortality strategy refresh. Are we happy with that? Brilliant, thank you. And we are on to the last 2 items. First one is the work programme.
It's me. I'll be quick. It's in the pack. As ever, I always want your suggestions for what you want to see. Otherwise, it will be what I put on the agenda. So please put your suggestions into down the line. Thank you. That's all I'll say.
Just from my point of view, we've had discussions of this before, but it's looking at the length of the reports that we get and how many items we have, and maybe look at having some, in-depth sessions about certain topics that people are very, very keen to discuss at length. So if we can look at that maybe in the next steering group. Thank you. And the last one is the minutes from the last meeting. Are people happy with the minutes? Are there any matters arising? I have one.
Just one thing on the minutes. Professor Gibbons will be delighted with his promotion to professor. He's a doctor.
Okay.
I'll call him professor from now on, all that said.
Okay. So I only have one matter arising, which is on the last page. It's about the membership of the ICP from the local authority point of view. We discussed it after last meeting at the steering group, and we approached a housing representative, not from the local authority, and voluntary sector. So Helen has agreed to be there as a representative from the voluntary sector, and Julianne Hall is from South Yorkshire Housing Association. They've already attended one of the meetings, and it's really good to have that kind of perspective in that forum. Next meeting, it's on the 30th of March 2023 at 2 p.m. in here, and I think Zach will chair that, hopefully. And there is a mini conference sometime. Do we have the okay, so a date is coming for the last one. And that's all. Thank you very much, everybody, for being in this really cold room for such a long time. Thank you.